Hey, good morning. Today is May 13th, 2026. So we have the board members and Mr. Smith. I'll call to order the Green Mountain Care Board's hearing. We have two agenda items today. First, we're going to get an update from the UVM liaison, Mr. Smith and his team. And then second, we're going to continue our Critical Access Hospital Medicare cost sharing work group meetings. With that, I will turn it over in a second to Mr. Smith, but I did just want to recognize and appreciate the work that the liaison team has done. And I'll give a little bit of a background of how this came to be. UVM had a budget overage, two budget overages, and the board and the UVM board got together and decided that we need to come up with a different path. And we need to find a solution to rising healthcare costs and some expenses that were going on at UVM. And I wanted to commend the UVM board members who worked with us on trying to find a solution. And part of that solution was bringing in an outside liaison to help have an independent, objective view on UVM's operations and to be a little bit more closer to the data and the people and the issues that were going on. And Member Holmes and I discussed this, and there was one name and one name only that came to mind, and that was Mr. Smith. Mr. Smith is retired, but we begged and begged and begged, and he kindly agreed to take on this very, very important project. And he and his team have worked tirelessly for an extended period of time now, and very well with our team and with the UVM team. And Mr. Smith brought on excellent colleagues, Mr. Stephen Gorman and Professor Nancy Kane, people that we are familiar with and comfortable with and who've also done a phenomenal job. So a deep gratitude and thanks for all that you've done in connection with this work, and to UVM for participating in this work earnestly and honestly and objectively. And I think we're in a good place. And the report that's submitted to the board reflects that effort. So, Mr. Smith, I'll turn it to you and your team.
Well, thank you. On behalf of Nancy Kane, who, by the way, is listening in, but
we cannot hear you.
You cannot hear me.
I'm here.
Or is that just me? Hang on, maybe it's me.
Yeah,
I can hear him fine. So,
yeah. Okay.
I can hear now.
Can you hear?
Yeah.
I'll start all over. I did my presentation. No, I'm just kidding. Chair Foster. Chair Foster, thank you very much. On behalf of Nancy Kane, Stephen Gorman, and myself, the members of the liaison team, I want to thank you for the opportunity to present before you this morning. Nancy is on the line. She's commuting right now, so between Boston and Maine. So we'll have her, depending on cell service, how cell service is. As you know, our job, as Chair Foster said, is outlined in the settlement agreement, is to review and opine on management, budget, capital, and other decisions made at UVM Health. We have done that periodically through various memos submitted to the Green Mountain Care Board, as well as to both the UVM Health Board and the UVM Medical Center boards. We started this assignment in May of 2025, and we're hoping to finish in the fall of 2026. It would be fair to say that at least two of our previous memorandums have been highly critical of UVM Health in terms of how they used to negotiate reimbursement rates with a healthcare insurer, and two, in their 2026 budget submission to the Green Mountain Care Board, where the budget narrative spun one tale while the actual budget numbers did not support the narrative. If you remember, we pointed out there was a big discrepancy between what was being said about the numbers as opposed to what the actual numbers said. And we were critical of the spinning in their budget narrative to make the budget look like something it was not. In the past, we have been very critical of the top-heavy executive organizational structure and the duplication of responsibilities. With all that said, we believe that UVM Health has taken positive steps to address those concerns, and that the new leadership has a more realistic view of what UVM Health should be and how it should get there. While at the same time, we do acknowledge that it's important to point out that there's more to do. So in our latest memorandum, we decided to look forward and try to concentrate on some of the existing and future challenges at UVM Health, and then recommend actions to help meet those challenges. To accomplish this, we brought in a consulting firm, Alvarez and Marcel, to help us analyze and report on three things: a set of affordability metrics to track progress in the upcoming years, UVM Health's clinical productivity relative to industry peers, and a multi-year financial plan for UVM Health reflecting the reimbursement challenges and expense trends. And although there are many pages and findings in the attached Alvarez and Marcel reports, instead, in our memo, we highlighted the broad three main findings and recommendations, which I'll spell out here. First, healthcare is unaffordable to many households and businesses in Vermont. That is not a surprise. There's been multiple studies that have confirmed this challenge, including the 2024 Oliver Wyman report, the Milliman data on marketplace premium growth, the Vermont Household Health Insurance Survey, and we confirmed it through various metrics, affordability metrics, through the A&M study. Therefore, we recommend that UVM continue the process of reducing prices charged to commercial insurance patients, especially those services priced 500% or higher than Medicare rates if affordability is to improve. Now, they can't do that in 1 year, and we recognize that, but methodically work to bring these costs down, especially with the upcoming reference pricing. This is an important sort of project that they must continue to do. Secondly, UVM Health needs to organize and operate its medical group operations, so roughly 154 outpatient clinics and 1,000 providers, in a much more efficient manner to increase patient-facing time and reduce expenses. In FY 2025, the medical group suffered financial losses of approximately about $280 million. Now, these sort of losses in a medical group are to be expected in most places. The size of this was a little bit alarming to us. Because these operational losses are offset by UVM Health charging Vermonters higher prices for outpatient and other services. Wait times for patient appointments lag far behind industry standards, and clinical productivity is well below the 50 percentile of peer organizations. Therefore, we recommended that the medical group improve access to care, reduce appointment wait times, and to lower overall costs for patients receiving care at UVM Health. To achieve this, clinicians, and we laid out recommendations in the report, to achieve this, clinicians will need to dedicate more of their schedule to patient-facing time, improving efficiency in scheduling and performance of support functions. And although this may save up to $55 million, the main focus of this recommendation is directed to improving the patient experience. This will need a cultural change at UVM Health, and we believe that that's beginning to happen with leadership acknowledging that this needs to happen, the culture change. Third, and this is the one getting a lot of press, but I want to mention that the two that I just mentioned are equally important, talking about affordability, talking about the medical group, and the mission to reduce appointment wait times and lower overall cost of for patients. Those are equally important, but this one has been getting a lot of the press, is that we believe, as we look out into the future and we scoped out the revenue and finances, that UVM is going to be facing a fiscal challenge in the upcoming years. Those fiscal challenges are driven by three key factors: a need to reduce costs so that care is affordable for its patients, an adverse future economic landscape driven by rising expenses and reimbursement pressure, and three, an urgent need to operate much more efficiently. So our recommendation, after looking at all the data and the various scenarios in that data, we're recommending that UVM Health must reduce its expenses by at least $300 million over the next 3 years, or about $100 million a year, or 2.8% a year, starting in FY27. The reason that we're recommending this phased approach is to lessen the impact on the state of Vermont, UVM and its employees, and the healthcare system, and try to sync up or synchronize with other statewide transformation efforts. Any way you look at it, this reduction has to take place for two fundamental reasons. One, affordability for healthcare in Vermont, and two, and equally important, sustainability for UVM Health. They need to reduce their costs for those two important reasons. Everything in the memo, members of the Green Mountain Care Board, everything in the memo expands on these 3 points with charts and graphs that support those points. And before we take questions on the memo and the 3 points, I do want to take a moment to point out that we do have some recommendations that will help with the implementation of the recommendations in the memo. They aren't in the memo. Point them out in terms of the budget, and trying to I'll kind of rush through these because they are lengthy, but we'll talk with the board later on in terms of what the specifics that we're talking about. We do believe that there will be, in order to sort of complement the $300 million in expense reduction, there should be some sort of planning on how this is done over 3 years, and therefore maybe we look at the Green Mountain Care Board adopting a multiple year budgeting or guidance process. We've got details on what it would look like in that process. I won't go over them right now, but the one thing that we've said repeatedly in memos is that the time for setting guidance is a short 1 year horizon, which sort of discourages a longer term approach to investing in organizational and system transformation. And what we found interesting is that we're recommending a budget or a guidance process and mechanism that allows certain hospitals that submit a viable 3-year strategic plan and budget to receive a multiple year budget and or guidance approval, with the understanding that their plan and budget or their guidance will be reviewed annually by the Green Mountain Care Board to ensure that it's in conformance with the 3-year approval. I lifted this mechanism, quite frankly, although it's not identical to the budget mechanism used by the Vermont Public Service Board. We also have talked repeatedly in our various memos about the budget process and how much burden it puts on the Green Mountain Care Board and how much burden it puts on the hospitals. And it's important to point out, we have said this before in other memos, and this is a quote from a previous memo: the level of technicality of the discussion is a good illustration of how the budget review process suffers from information asymmetry favoring the health system, with a full staff of financial professionals capable of figuring out how to maximize revenues within a complex set of rules. And we understand that there's much responsibility that's been placed on the Green Mountain Care Board. We also recognize that the Green Mountain Care Board must operate in an ever-changing healthcare environment. And oftentimes, these responsibilities are expanded by the legislature, and sometimes this information requests are driven by hospitals themselves striving to develop other non-regulated revenue and the board's desire to get a fuller picture. We're looking at a consistency in the budget process as we try to compare year to year. And the hospital, for example, expenses, the hospital current year expenses should include a 3-year look back that shows the year-over-year increases in both dollar and percentages. We have some more similar ideas for revenue and similar ideas for volume and utilization, and develop a consistent and more readily understandable method than the rate decomp sheet of tracking patient volumes. I don't want to delve into that because we do have specifics that we can delve into that, but just some thoughts here. And Stephen, you had at least 2 areas that you wanted to discuss. I just
Yep, I can cover those, Mike.
okay. I
Great.
just got a threat warning here, so I'm just going to move it to quarantine. Thank you.
Yeah, there were 2 things I wanted to highlight. One, when we published the memo, we had a lot of questions from various stakeholders asking about the impact that this would have on premiums. And, we had asked for participation in this process from Blue Cross Blue Shield. They declined to participate, saying the amount of work that would be involved in projecting rate increases was going to be too high. I frankly think we need more involvement from Blue Cross Blue Shield and MVP in projecting what premium increases are going to be in order for the Green Mountain Care Board to do its job. So that is one point I wanted to make. But the second point is that I believe there's a perception across many stakeholders that the UVM Health Network, is the driver of healthcare costs in Vermont. I think everybody is aware of the statistic that UVM Health accounts for 65% of the revenues of all Vermont hospitals. So certainly from a hospital standpoint, it is the 800-pound gorilla. But when you look at the breakdown of all of the healthcare costs in the state, the UVM Health Network accounts for 24% of the total medical costs. So 24% is significant, but it is a much smaller impact. And the reason is we have costs associated with pharmacy benefits, and we have costs associated with the non-regulated entities. The non-regulated entities are the individual medical groups, as well as hospitals that receive payment from our insurance companies that are not in the state. And just for context, for anybody that is not aware of this, pharmacy benefits account for 23% of Blue Cross Blue Shield's claim costs for the QHP plans. The regulated hospitals account for 37% of the claim costs, and the non-regulated entities account for 40% of the claim costs. So that's how you get to the 24% overall impact. So again, UVM is critical. It's important. We should focus on them, but we should not ignore the other realities. That is especially true when you think about the non-regulated entities. So from 2022 to 2024, it was the 14 regulated hospitals that were seeing their costs go up by the highest amount and were contributing to the greatest percentage increase in Blue Cross Blue Shield claims being paid. However, the actions of the Green Mountain Care Board starting in 2025, starting in 2024, really changed that. And in 2024, regulated costs went up 8.6%, while non-regulated costs went up by 13.1%. And in 2025, regulated costs went up by 7.3%, while non-regulated costs went up by 10.1%. So obviously the Care Board is focused on the regulated hospitals, but I would encourage the Care Board and encourage Blue Cross and everyone to not ignore the non-regulated entities where the cost controls that have been effectively placed on the 14 hospitals, they seem to be flying under the radar. So that was the first point I wanted to make. And the second point I wanted to make is on the budget guidance that was provided to the hospitals. There's effectively a 1% decline in the commercial insurance cap. There's a 1% decline in the commercial insurance rate. And obviously the Care Board has said the insurance companies should negotiate further at all costs, but historically that has not happened. And if the revenue cap is set at the same percentage as the price cap, then we leave no room for volume increases. And we all know that we have a patient access problem in Vermont. We highlighted the patient access problem in the memo that Mike Smith just described. And there is an effort underway for UVM to increase provider productivity. But if the price cap and the revenue cap move in lockstep, then that productivity improvement is going to cause a problem. Now, importantly, when the Green Mountain Care Board issued its guidance to the medical center for 2026, there was a significant gap between the price reductions that were regulated and the commercial revenue cap, which left room for productivity improvements. What the Care Board did in 2026, I believe, is critical to do in future years for the health network and other hospitals if Vermont is going to address this access challenge that we have. Thank you.
Okay, Stephen. Before I'm going to wrap up here, I want to make sure I'm going to talk about transformation and then go to conclusion. But Nancy, do you have anything you want to add while you're traveling here?
No, I think my only, I'm in the same boat as Stephen and you about the complexity of the budgetary process and the enormous amounts of information, some of which is redundant. And I think there's a real need to reduce that and make it manageable and a process where there's a whole part of the budget guidance that says, okay, if you don't hit one of these benchmarks, here's 15 different ways you can show that you why that is. And I think that just makes it very hard to achieve a consistent controls over the costs and the revenues. So I'm just thinking we need to really think more about what information do you really want, and what kind of reasons for not staying within the cap you think are acceptable. And that's a whole process that we have to talk about in the future. That's all I have to say. Thanks.
Thanks, Nancy. You're coming in loud and clear, by the way. The other thing I wanted to talk about, and we probably will focus a little bit more on it in the future, is the whole sort of transformation effort that's going on statewide. And as we had mentioned in the memo, that there really needs to be close coordination with this as UVM starts to reduce its expenses, making sure it's in coordination with what's going on elsewhere in the state so that we don't lose service in areas, and we make sure that we go to the lower cost alternatives that are out there. And there's a lot going on in transformation. I mean, you know, they're underway right now through the efforts of the Agency of Human Services with and legislative support through Act 167 and Act 68. Um, the AHS testified recently at a House Healthcare Committee that there has been initial progress in the area of shared services, care setting shifts, and hospital optimization initiatives. They've collected initial plans from each hospital regarding how they envision transformation. Their estimated need for resources, including technical assistance and analytics. However, what these early efforts, and we reviewed UVM's response to AHS request, and there are at least 3 or 4 of them that we firmly agree with, such as common EHR, patient transport, helping out with specialty services and home health. Those efforts are designed to keep care or move care to lower cost of sites, and we wholeheartedly support them. But the efforts do not appear right now to be sufficient or timely enough to help UVM Health's immediate needs to begin to reduce expenses, nor respond to a more successful and more robust sort of transformation effort. And in order for UVM Health to succeed in expense reduction, it needs to proceed expeditiously. And we're just saying right now, there needs to be the transformation effort needs to catch up with this, or it needs to be coordinated in a more cohesive manner in order to be successful, both at UVM and what it's going to do, and at the transformation effort. I'm just going to conclude with this. UVM Health needs to urgently address its financial and productivity issues to ensure affordability, sustainability, and a much better patient experience. Failure to address these areas is having, and will continue to have, by the way, significant negative impacts on UVM Health and the healthcare system throughout Vermont. In terms of changing the trajectory of projected budget deficits, there is little choice but to address them for 2 reasons. First, Vermonters, through their premiums, are already struggling to afford UVM Health services. And second, traditional revenue sources are becoming constrained. If these challenges are not addressed, they will have an adverse impact on UVM's future viability. I want to make sure that I mention this. UVM is gifted with a talented workforce that now needs to be engaged and guided in a different direction to enhance productivity and reduce patient wait times. Leadership understands the challenges and the need for a change, and leadership has been supportive in the key findings in this report. The liaison team is really encouraged by the commitment to implement recommended changes. And however, it's not going to be easy to translate that commitment into implementation. So implementation is going to be key here. But it also is encouraging to see that UVM, through its, although it has its challenges ahead, is pursuing a path of cooperation to assist Vermonters in their struggles with having access to timely, affordable, and quality health care. I just want to end with this. UVMH is a partner the state needs, and the state can be a partner that UVM can rely on if UVM continues to pursue this path of cooperation. And so far, we've seen night and day in the beginning when we started and what they're doing now. And we'll conclude with that.
Thank you all very much. I have 2 quick questions, and I'll turn to the other board members. And just for the public, how the work group, we had a work group that was structured, and just so I want people to understand this, the liaison team, Mr. Smith was part of the work group. UVM had 2 board representatives as part of a work group, and then the Green Mountain Care Board had 2 board members as part of a work group. And then Mr. Smith's team retained the consultants who helped with some of this data. I want to thank Member Walsh and Teach Out for serving as the board representatives on this. 2 brief questions for me. Stephen, you raised the point about the productivity improvement that we want to see, and I agree with that. You mentioned that we need a little bit of room. The price needs to be low enough. We need to set prices at the board that allow them the space to go up to the cap. And I agree with that. One of the challenges I see, though, is our ability at the care board to anticipate that growth and productivity, right? It's a very internal exercise that they have good data on. And I personally, as a board member, don't feel that equipped in a compressed budget process to, make that kind of determination. Have you recommended to UVM that they submit budgets that allow for that space?
Yeah, I think it's a great question, Owen, and we are going to be working with them on their budget submission. That's a relatively new development that Mike Smith and Steve Leffler started talking about. So, we can certainly do that. The main point I wanted to make and for people to be aware of is that the intent of the cap, the net patient revenue cap, which was all payer, was to drive down prices. And in effect, where the rubber meets the road, that wasn't really happening, right? The revenue cap ended up, I think, contributing to the patient access challenge that we had in Vermont. So somehow, some way, we need to make sure that the efficiency of the organization and being able to see more patients, reduce the cost structure, reduce the wait time is encouraged by the rates that are set and the caps that are put in place, and that we don't do the opposite. So, and there's some, refinement to what we need to do, but what the main point I want to make is how it's been done up until the 2026 guidance has had the opposite effect on the ground from what I believe the care board intended.
Maybe potentially. I mean, they did go over their budgets, a number of years in a row. So I don't know if the cap really was necessarily a limiter. I think it was probably more of a productivity side things from my view, but I'm not that close to it. So yeah, I do think it'd be good. And if you work with the budgeting, if there's a sense of, hey, we need space, so submit the prices needed to have that space, that would certainly be helpful. The other thing I'd consider is we deal with budget overages through enforcement. And in the past, we enforced in full on UVM. And our decisions reflected what we found to be some creative budgeting around Medicare money that was coming in. It was actually under budgeting Medicare revenue in our sense, in a way that was not necessarily appropriate. But when we deal with enforcement, what we're trying to get at is appropriate productivity increases. So if there is an appropriate productivity increase, and not just like an uptick in the coding levels, or not just an uptick in, hey, every cortisone shot is now an ultrasound guided cortisone shot, as opposed to, there are ways to mess with productivity that do not reflect appropriate utilization. And that is something that's very, very challenging. I just want to flag that, because what we should be doing in enforcement is, if it's truly appropriate utilization, it shouldn't be enforced in full, or we should consider not enforcing it in full. So that's another thing we should think about, is how we enforce, and any recommendations you have on that, I would definitely like hearing about. Then the last comment, I really appreciate you going through the non-hospital drivers of our rate increases. That has been an intent of the board to get the regulated entities more in line with appropriate expense increases, and to not be such an outlier. We've started taking steps that have improved on that. Your point about non-regulated, non-Vermont hospitals and pharma, we're aware of it. I don't know if we talk about it that much publicly as a board, since we're not regulating it. But the other conundrum I have is, what do we do about it? Given we don't have any authorities over it, who does and how do we tackle that component of our rate problems?
Yeah, the comment I would make, and whether it's DFR or whether it's the care board, I think the pressure needs to be applied to the commercial insurers. I think there's a view that if their prices are lower than the highest price hospitals, then we should, leave them alone. But the reality is, if their costs are growing faster than the regulated entities, that is going to drive up premiums. So I'm not sure of all the regulatory authority, but I think it's payer focused more than care delivery organization focused, based on what your remit is as a regulator. And the only thing I wanted to comment on the overage, Owen and everyone, I think there's two ways to think about overage. One is that there's a deliberate intention to go over, and the other is just the variability of patient volume from year to year, right? So a UVM in any hospital does its best to predict things. I've run businesses. You're never spot on, right? Stuff happens. My point is, we should systemically set something up that encourages more utilization. And the issue of overage, if it is, unintentional or related to volumes, we need to, deal with that. But there should be a incentive that the hospital should need to be more efficient each and every year in order to achieve the same level of financial results. That's the big piece. And the final thing I will say, which I believe is contemplated in the 2027 guidance, is focus the cap on commercial revenue and Medicare revenue. If that grows because we have more seniors and those seniors need more care, it's not impacting the direct cost to Vermonters, and therefore, I don't believe should be the key focus of a cap.
And it is, when we do have a lot of pressure appropriately to watch the insurance rates and to do a good job on the affordability side, there is a bit of a mismatch, as you noted, that our regulatory authorities are really over 14 regulated hospitals, and being cognizant that we can't drive all affordability in the system on the backs of our hospital system, and being balanced in that is important for us to not get siloed in our thinking. All right, thank you. That's all I had. Member Teachout?
Great, thank you. And thank you for the report. I think one of the things I think about and would like to hear more about is actually the implementation. It's the thing that you identified, Mike, as the next step. You've done a great job identifying what the issues are, where the hospital needs to be more efficient, where the revenue problems are, but now it needs to be implemented. And I'd like to hear a little bit more about if there's a plan to get to where it needs to be. I know you've said 3 years. I know you've said 2.8% a year, but actually, what are the steps that are going to make that happen?
Well, thank you for that question. I really do appreciate it. It's timely too, because on Friday, the liaison team's meeting with the medical group hierarchy to talk about where they are in the first month after we release this report, and where they are in accordance to some of the steps that we have pointed out. Where are you with locking down the schedule? Where are you with various leadership, making sure leadership is involved in that? That's going to happen on Friday. As Stephen mentioned, we're probably going to have a much more active role in the budget, not to say you should cut here or cut there. It's going to be, how you going to get from here to there, and is it appropriate how you're going to get from here to there? And so I think with those two mechanisms, in terms of implementation, taking the time schedule that we have from the Alvarez Marcel report, checking in, it will probably be monthly that we will check in with them on where they are starting on Friday. And then also, where are you with meeting the needs that we have said that you need to do, the 300 million, the 100 million a year. Dr. Leffler and I have discussed, we want to know how that is coming together. And he has been gracious enough to say, sure, do that. The other thing that I've asked, and again, Dr. Leffler has been gracious enough, they have a meeting on implementation on certain issues that are coming up. I had talked about lean previously to the working group and whether we need it or not, but they have put together this working group with the presidents, department heads, to tackle issues. And I've asked to sit in on those meetings to make sure what issues are coming before them and how they're moving forward on tackling. So in terms of implementation, we're starting to turn to that now. And I think you will see the rest of our time focused on implementation, frankly, as we move forward.
Great. Thank you. I'm also,
And Sarah, sorry, the only other comment I would make is that I think both Mike and I and Nancy believe that the senior leadership is completely on board with what needs to change. And I think that's a big break from what has occurred in the past. But, we have concerns because ultimately that leadership needs to impact the culture of the organization. And there's 1,000 physicians and 10,000 employees across that organization. So it's not something that's going to be transformed in 1 month or 1 quarter. So we are well aware of the amount of effort that it's going to take, and believe that we as a liaison team are going to stay on top of it. But our engagement is limited, as Mike just said. We're going to be finishing up in the fall, so that might be a point of discussion at that point as to how do we ensure a continued focus on this transformation.
Great, thank you. I appreciate that. And discussing it again as you kind of close out your work, I think would be very helpful. Another thing I wanted to ask about was the budget recommendations that you're going to have for us, because I do really think that, the way we handle our budget guidance and our process, we want to enable the hospitals to move in the direction that we've asked them to. So do you anticipate working with our team or giving us, you've talked high level, but I think we need to get really deep into the details of, our, that spreadsheet, I'm forgetting the name of it right now, and the information that we ask for, helping us think about what we really need from hospitals to guide them in the direction we want them to go in.
You mean the decom sheet that drives Nancy nuts?
Yes. Yes.
Yeah, I'll circle back with that, Sarah.
Okay, great. I think I only had 2 other things I wanted to ask about. One is, you've been working with a really complex hospital system. Do you think that this type of work can be repeated at our other facilities across the state? Not you doing it, but is this a model that can be replicated? Or is it really unique to each hospital?
I don't think it's unique. I think it can be replicated. I have to retire at some point, but that's but I think it can be replicated.
The problems might be
the
different.
only follow-on, sorry, Sarah, that I want to point out, and Mike, I'm not sure we covered this, but we talked about the $300 million of pressure that's going to be applied to UVM as a result of basically reimbursement changes. The other hospitals in Vermont are not immune from those same pressures. And so, everything's relative based on their size, but the problem that is facing the UVM Health Network is the same challenge that's facing the other hospitals. They do not have the report. We haven't done the breakout, but this gets to your question. They cannot continue to grow their expenses at the rate they have been in the face of the reimbursement environment that is currently upon us. And that needs to be reckoned with, and that gets to the whole transformation effort that Mike brought up. But I just want to be clear for everybody, this is not unique to UVM, the headwinds that are being faced. And
Nancy, you wanted to say something, didn't you?
No, I was just going to say their problems might be, other than the economic headwinds, I think their problems might be different in that a lot of the way healthcare is delivered is changing dramatically these days. And particularly the community-based providers may find that most of what they do can go outpatient or can go home. And there may need to be a rethinking of their entire way of delivering care, much more fundamental than what's going on in a tertiary academic health center, whose fundamental mission, may be slightly tweaked, but not nearly as much so as what's going on in the communities. And in other areas, other states, there's a lot of transformational change, reducing the inpatient footprint and expanding the community-based and home-based outpatient footprint. So I think there might be more service change, in other words, that might happen at other hospitals than at UVM.
Thank you, Nancy. The last question, and you actually touched on it in your previous answer, was I remember the consultant saying that the project here in Vermont was different than what they typically do across the country and with other hospitals, and that that the problems that all the hospitals are facing cannot be solved with just increasing commercial revenue. And I thought that was really interesting when we were speaking with the consultant and really telling about the types of projects that they work on. If you could elaborate just a little, that'd be helpful.
Yeah, and Nancy and Steve, you can chime in too. But the landscape, and I've heard Dr. Leffler say this, so I'm not. The landscape has changed tremendously in terms of revenue. It used to be pretty easy to do your budget. You figure out what you're going to have in Medicaid, Medicare, and the gap you fill it up with the commercial side of things. That's no longer the case, and it is a lot different in terms of the environment here in Vermont. Secondly, other states are we were specific. We said there isn't revenue to grow. Look at the affordability in Vermont. There isn't revenue to grow here in Vermont, whereas other states there may be revenue, but there isn't. We're really taxing Vermonters in terms of healthcare cost, and so there isn't room to grow anymore in terms on the revenue side. So we have to match our revenue with our expenses. In this case, it means bringing down our expenses because there isn't any revenue. Stephen and Nancy,
Yeah, the only other comment I would make is that I think the structure of the liaison team and the settlement agreement and the charter and how the consulting dollars were funneled was very important, because there are times that the consultant would say, well, when we work with other hospitals, let's talk about some strategies to increase revenue. And Mike and Nancy and I would be like, don't waste your time. We're not looking for revenue improvements. We're looking for, expense reduction. So, typically if it's a health system that, hires a consulting firm, they have one stakeholder, which is their own organization. But having the liaison team with the affordability at the seat driving the conversation along with UVM Health made sure that the balance that Mike just described was in place. So I do think the structure of the liaison team, the work group, and how the care board set up this entity was very beneficial in terms of the guidance provided to the consultant.
I think also the focus on access, that patient access needed to improve, was not every health system has the problems of access that you do in Vermont. And we, just like as with don't look to revenue, we also said we need to improve access, not just cut expenses. So not just the financial stability, but making the healthcare experience much more patient friendly and affordable and accessible.
Great. Thank you all. That's the end of my questions.
Thank you. Member Walsh.
Thank you, Chair Foster. Mr. Smith, I just want to start off by thanking you for your work on this. And I also wanted to note, as you have, the shift in cooperation from the leadership at UVM. It's been noteworthy and welcomed and feels very productive. And that's a great thing. It's been interesting listening to your presentation and listening to Chair Foster's questions and Member Teachout. There's been a lot of focus on clinical productivity in the memo and in the conversation so far. It strikes me that if we're trying to think about improving access and improving productivity, that's typically associated with increasing utilization within a system. If utilization is going up and prices are high or going up, the revenue in that system would rise. But we've talked about how we need to not keep raising revenue. Vermonters are tapped out. There's just, it's unaffordable as it is. So if revenue is constrained and utilization needs to go up, then the prices need to come down. And if that were to happen, it seems like the focus really, as you and Mr. Gorman were saying, needs to be on decreasing operating expenses. And when I think of a health system, there's layers of efficiency and productivity. There's the direct patient care layer, but there's also just what keeps the clinics running, what keeps the departments running, what keeps the network administration, the corporation running. So all those layers above the direct patient care. And I'm wondering if your group has examined whether the network structure itself, that those upper layers are really producing measurable value for patients and communities relative to the cost and complexity of those layers, given that the volume of patient demand has not grown significantly over the last 10 years. We do have an access process problem. It does have to grow, but it hasn't been. But the upper layers seem to have ballooned.
Yeah, that is a really good question. And I will say this, in the beginning, we wrestled with network versus no network and looking at it. And in theory, networks can be an efficient way to deliver healthcare services. And in the case of UVM, it did have some benefits when it helped struggling institutions like Central Vermont or Porter, or as well as in the North Country over in New York. We did not recommend dismantling the network, even though UVM did not operate the network in an efficient manner. And you are absolutely right. We found that it was top-heavy, overbearing organization structure, and we felt that even with that, we felt that we weren't going to recommend dismantling the network for 3 reasons. One is the organization has recognized that it's top-heavy and overbearing, and is changing those past organizational mistakes, and they've begun to address them. They haven't addressed them fully, but they have begun to address them. I think you'll see that the network C-suite is basically gone, and those positions have been consolidated into other positions within the local network. Number 2, we just felt it would be a legal. Maybe I just felt, because I don't want to surprise my other members, but I thought it would be just a legal mess trying to untangle this and diverting our attention away from the need to deliver affordable and sustainable health care in Vermont. That was another reason. The network, I believe, will have an important role. And my third reason, I think the network will have an important role in the transformation efforts that the state has embarked on. So I guess to answer your question, In theory, networks can be efficient. UVM has not been efficient. We believe they can be efficient in the future.
I appreciate that. It's there are examples of networks around the country improving care coordination and finding economies of scale, right? And reducing operating expenses at affiliates. We haven't seen that yet here, but it is possible, and it makes sense that trying to get the advantages out of the network remains a priority.
Yep.
At the same time, it continues to be something I think we as a board need to continue to look at deeply. My interpretation of your presentation today and the memo is that if there are operating expenses to be reduced at the medical center across the network, while there is a need to improve productivity of the direct patient care force, that reductions in operating expenses should not start at the clinical level. Would you agree with that interpretation, or
I would. Yeah, I would agree in that that interpretation. I think one of the first things that we did when we last year, when we first got this assignment last May, was we looked at expenses, and we saw tremendous growth in expenses over the last 5 years, especially in IT and revenue cycle. I may have brought that up to the working group, and we warned at the time that growth couldn't be sustained. So I think what the memo says is that you have to mitigate the expense growth for affordability. Well, I know the memo says that, for affordability and sustainability. And I don't know, there needs to be a hierarchy of expense reduction, and it has to start with admin, non-clinical, and then if there is service related, it has to have two considerations. One, how does that fit into the transformation effort that's happening on the statewide effort? And number two, how does that fit into making sure that we're sending people to the lowest cost location of lowest cost of care? So I do believe there's a hierarchy of decision making in that expense area. And the tremendous growth that we saw in the last 5 years should be the first place you look for reductions.
Great. Thank you. The last question that I had was to ask, if you were able to stick around longer, what more would you work on? I think member Teach Out asked that. Your response was more on implementation. I appreciate that response. So those are all the questions that I have.
Okay, thank you.
Thank you.
Member Merman?
Yeah, thanks. This is a huge topic, and I there's a lot in the memo and even more in this conversation. And I feel like we could have like an entire day symposium on this and really start to scratch the surface of a lot of the the meat of what's in this report. But few things. One, a huge thanks to Mike, Steve, and Nancy. I know you all have other things in your lives and family members and things to do, and that they pull you away from this important work for the state. And I'm sure retirement probably appeals to you, Mike, and I'm very appreciative of you putting that on hold, and of your family of letting you put that on hold for some time to do this important work. I really appreciate the report so far and this hearing today. I do think a lot of what's in, I feel like I need to divide this slightly, is a lot of what we just discussed today is a little different than what's in the report. And so I want to bear that in mind, but the report I really feel like corresponds really quite tightly with prior information that we've had during hospital budget hearings in the process. The productivity, we have more granular level productivity data from the hospital budget process has been really challenged in a lot of areas of UVM Medical Group. There's been a discussion in the past that the data wasn't reliable or accurate. I think that it's been directional enough for a period of time that I think that there are challenges there. High expense growth is something that I think we have had year over year and has been brought up. And high commercial prices, I think the RAND data was really helpful for that. The data that we get confidentially often helps us understand that. But we know that UVM has had high commercial prices for a long period of time, probably well preceding the RAND data, given that the price growth that they had over the few years, the RAND data really weren't that substantial, but yet their prices were really high. So I do think that this whole problem has taken a long time to get here. And when you talk about cultural changes that are going to need to be made, operational changes, and that this is not a quick, especially Stephen, you mentioned this is not going to be a quick fix. That I appreciate that, and balanced with we need a quick fix, or at least we need quick action to fix and start the process moving forward. So those are sort of just a few opening thoughts. I want to just sort of address a few things that have been talked about so far. And I think it's a really interesting topic that Steve brought up, and Owen's conversation is the idea of the NPR caps and commercial price growth. And I feel very strongly on this as well, that I think if that we need to have commercial price, we need room in NPR for productivity to occur to not blow through the NPR cap, so that commercial prices get, in this day and age, reduced enough so that NPR can grow. And I do agree, and I think this is sort of an area I just wanted to talk about, and then I'll get to questions. I apologize for the monologue. That in many ways, when I look at what we've done is fairly akin to a global budget where we didn't really enforce NPR growth that much over, and that's we, the Green Mountain Care Board, but my understanding it predates that with Bishka and even predates that there was an NPR cap and a commercial price was filled in to get to that cap. What I see that doing is exactly what Steve was discussing, is you don't incentivize efficiency, you don't incentivize productivity, and in the failure state of a global budget is where you have low productivity and high prices. And that's kind of where we are. We have low productivity and high prices. And so to get out of that, I really view we need to incentivize productivity and thus access and thus utilization, and trying to bear in mind the right kind of utilization, which is very tricky to manage and monitor. But I don't see a way where I see the easiest way, or the way to get out of that, is to reduce prices so that you incentivize productivity to get to that NPR that we can tolerate. One of the challenges, though, I think that we have, and I think, Steve, you mentioned this somewhat in your description of the pharmacy benefit, the regulated entities and the non-regulated entities, and the growth rates, is that while the growth rates are higher in the non-regulated entities than they were in the regulated entities for the last couple of years, the base is so high in the regulated entities that even if the rate growth isn't as high, the spending growth is still, the spending is so high in those areas proportional to what we should have. So yeah, anyways, those are just some thoughts. I don't know if you want to comment on those. There weren't really any questions in there. It was just sort of reflections on what we've discussed so far.
Yeah, Stephen, do you want to weigh in on that?
Yeah, this is a general comment just on the whole relationship between prices and productivity and the net patient revenue cap. Jeff Bezos at Amazon was quoted as saying to his competitors, "Your margin is my opportunity," meaning if he could do something cheaper, he could take market share from Walmart or whomever. So their model has always been, we have to be more efficient, lower our cost structure, drive down prices so that we can grow and take share from. So there is something, if you knew that your prices were going to incrementally come down over a 3-year period of time, or whatever the planning horizon is, and if you're a business, you generally would be like, okay, well, what do we have to do in order to, maintain our growth, maintain our employees, continue to be an ongoing entity. And usually the solution is, well, we've got to get more efficient and we've got to be able to, do more in order to get to the same revenue. So I think pricing can be used as a driver for efficiency. But David, you bring up the point that, we want the right kind of efficiency and the right kind of utilization and not the bad kind of utilization. So the analogy to a non-healthcare business is an imperfect analogy, but I just want to make the point that the fundamental notion of, visibility into pricing as a driver of efficiency, I think does hold. And the only other comment I would make just on I totally appreciate the fact that the regulated entities have a lower price point, right? And that all things being equal, we would like to see more services, being performed at a lower price point. However, what I was quoting in terms of the growth rate, that is the total claim cost that Blue Cross Blue Shield is paying to these entities. And I don't have the utilization data, but I suspect that the increase in claim costs to these non-regulated entities was not all as a result of, volume transfer out of the hospitals. I think they have been allowed and enabled to drive prices up because I think everybody's been focused on these very high-priced entities. And just the way the math works, we are not going to see premiums reduced in Vermont unless we somehow contemplate the non-regulated entities in what we're trying to build. So anyway, just some context on that.
One other sort of context in that too, and I think we don't know is sort of part of the challenge, and there's data gap here. But one thing that I think when I got on the board, it was clear is that a lot of the non-regulated entities had been price constrained for a long time through the board, kind of trying to constrain price growth through insurance premium reduction, but not through hospital spending, so that the lever that the payer has is on the non-regulated entity to keep their price growth down. And then I think over the last couple of years, knowing sort of the challenges of the independent providers and non-regulated entities in Vermont, the idea was that if we can control the hospital growth a little bit, we can make a little bit of room in the commercial insurance premium dollar to then transfer into a price increase for the lower cost non-regulated entities, which I think is important because we want to have a viable non-hospital based system if we're trying to move care out of hospitals into lower cost places. So I think there was some intentionality of that over the last couple of years. And I think also, a lot of that non-hospital, non-regulated revenue is going to hospitals outside, like to Dartmouth and Boston and those areas. And they, I don't think, saw the price increases that the Vermont hospital saw in FY23, but then I think had it come out more evenly over FY24, FY25. So I think it's part of it. But I agree, it can all go off the rails if things aren't being watched carefully, and I hope that the payers are super active in that.
Yeah, it's certainly a complicated issue, and I think to me it's something we need to think about, not resolve here. But if we just look at the overall demographics of Vermont, right, with a relatively stagnant employee base, relatively few young people, more people aging into Medicare, the notion that utilization of these non-regulated entities would be driving 13% and 10% increase in claim costs doesn't pass like the smell test. Like there's something going on with pricing there. And I just think we have to understand that, and probably to the extent that you or the DFR, somebody can apply some regulatory focus on the insurers to get to the answers of many of the questions that you raised, David. That's really what I'm focused on, because something is odd in terms of our demographics and the price growth that is going on.
Yeah. There was an interesting discussion about the network. I guess I'm going to sort of not get too deep into that right now, but I do wonder sometimes if it's not a question of network or not network. I think, as Tom was getting to, it's how the network is organized and how the functional units are organized in the network, and where the administrative inefficiency kind of gets woven in below that C-suite layer, the many, many, many layers of administration that are occurring in the sort of horizontal, let's have everything equal across all sites. It's a very complex process to develop, with this large of a group of people who have very different cultural, institutional values, who have very different resources, very different lives, clinical environments to homogenize it. And I think that's been an effort that has been challenging. And from my view, I think it's been very labor intensive and not really very fruitful. So I don't know if someone came off mute there. I don't know if you wanted to add on that, but.
No, I think we are in agreement with that it has not been an efficient system, and it needs to be an efficient system in order to sort of see the advantages of a network, and it has struggled to do that. You're absolutely right that just looking at the C-suite of the network and making changes there isn't enough. It has to go down even further into the organization. And I don't mean to say it can stop now. It shouldn't. With $300 million of expenses out there that needs to be reduced, I think you should look at those inefficiencies that are even below the C-suite that we talked about.
Yeah. One thing that I worry about in all of this, or maybe one thing I've been trying to understand in all of this, is that I think you've identified, and we've known for a while, that there's been a lot of operational challenges, a lot of inefficiencies, and high commercial premiums. And we know that Vermont has very high per capita spending. And I'm trying to understand what has been the cost? What is the annual cost of this inefficiency that we're experiencing now? What have Vermonters paid for this over time? And I was looking back through a slide from our hospital budget process last year, and there was one: if UVM had grown at the 4.2% growth rate in NPR that we had set in 2017, it ended up being $684 million. They've grown $684 million above that growth rate in cumulative growth. So that's $684 million that have come out of, for the most part, Vermont commercial premium money to support these inefficient operations. And I think that probably really underestimates the true amount, because we know in 2017, UVM probably already had really inflated commercial prices. So it could be substantially more. And I just was wondering if there was any, I don't know if it's valuable for your work to understand this amount, but if you have any other sort of ideas of what is this costing us as a state to have this inefficient delivery system?
Yeah, we didn't delve into that, to be honest, but let us look, David. That's a good, yeah. It's a good point to know. So.
Yeah, the only sort of the only context I would provide on that is UVM is not alone in that the country's academic medical centers are the most expensive places to get care. And, the way they have to have their mission be partly clinical, partly education, partly research, they are not set up to be the low-cost provider. The challenge that we have in Vermont is that our, largest hospital happens to be an academic medical center. So a lot of the care, 24% of the care in Vermont, goes to this high-priced entity. And that's just a factor we have to acknowledge. The academic medical center could certainly be more efficient, but the structure of that entity is never going to be the super high efficient, high throughput organization just by nature of their charter. So I want to point that one thing out. And then the second thing, which doesn't impact the main point you're making, David, about whether it's the $600 million of overcharge, but We also have, relative to the premiums, we do have a demographic challenge, right? We do not have a lot of young people. The people that we do have that are on commercial insurance do skew slightly older than the national average. Young people pay into healthcare with premiums, but don't use a lot of care, which drive down rates. So there are some things in Vermont that are demographic related and just the nature of being a small state that do work against us. And I just want to point those two items out.
You know, I agree. Actually, I recently, this is Medicare data, so not commercial data, but pulled out a random list of academic medical centers and looked at the prices and said, okay, so what percentage of healthcare in all these different states, kind of Medicare data for all the states, that's hospital-based healthcare is provided for at an academic medical center in the state. And it turns out Vermont was one of the top two. And Vermont has very little healthcare outside of the hospital system. So we're probably even concentrated more. And that doesn't even include Dartmouth, because that was only Vermont claims in Vermont for Vermont hospitals. So I totally agree. We're very concentrated in the academic medical center, which I think does create this structural issue for us. And there isn't really a community hospital that has a full service community hospital, like where you have a cath lab and 24-hour surgery and all these other services that could be provided at much more efficient cost structures. So, okay, back to the report. There's one thing I wanted to talk about. So we talk about this $38 to $55 million opportunity that UVM has for improving revenue based upon provider productivity. My question for you is, all that provider productivity probably leads to hospital revenue growth as well through facility fees, laboratory testing, imaging studies, additional referrals maybe that go on. Do we have an idea of what the hospital side, the non-professional revenue growth would be that was associated with that improvement in provider productivity that A&M calculated?
Stephen or Nancy on that one?
Yeah, the short answer is we don't have a number, but your point is well taken, right? And the stats for everybody on the call, UVM has not seen growth in its inpatient volume. I think it's been 1% to flat for the last couple of years. So inpatient is not the driver.
Yeah.
Their professional volume, the volume for the specific services that the 1,000 physicians provide, has been going up by about 4 to 5% a year, but that's all as a result of UVM hiring more physicians, not a 4 to 5% improvement in productivity. So the only way they get more volume is by hiring more doctors, and we need to fix that. The real volume growth has been on the ancillary services, the radiology, the lab, the stuff you just talked about, David. The relationship between, additional productivity on the physician side, how much of that gets dragged through on the outpatient side is something we should look at. But the guidance that the Care Board provided last year, which was take the 6% rate reduction all out of the high-priced ancillaries, which translated into a 20% decrease in radiology fees and others, is certainly a step in the right direction. And I think that's why we made the point about when they look at pricing, when the health network looks at pricing, they should look at those prices with the highest markup, because if we can drive down that price, then if volume on the professional side yields an incremental increase in lab work or radiology work, it won't have the same punishing effect on Blue Cross's claim costs that it has historically.
Yeah. Another sort of thing on the productivity side that I've been trying to understand, and I think, Mike, you referred to this to some degree as, cultural challenges, but, I'm an emergency physician. I work in the UVM Health Network. I know a lot of people who are physicians and other providers in the UVM Health Network, and there's a lot of concern right now about is the narrative that the woes of the UVM Health Network are because providers don't work hard enough. And I think, when you look through some of the scheduling stuff, I think there probably are people that are taking Friday afternoons a little bit earlier. I don't know how that relates to their FTE. And I do think, a lot of people in a place like Vermont are trying to balance, family with professional career, a lot of two provider couples and those sorts of things. But I guess my question is related around how are you viewing the productivity challenges within the medical group? Is it that people, the narrative that people worry about is that it's a bunch of providers not working hard enough? Or, and maybe I'm baiting the question slightly, or is there is it that providers don't have the systems to support them or the cultural support to be more productive, more productive, I guess. So sorry for a super baited question. I guess I
No,
laid my view
no,
in there.
I think.
Could I add? Okay. I was thinking it would be really useful, David, if you would look through all of the recommendations in the clinical productivity study and tell us which ones you think are not fair. Because we can't, you're on the ground and have a better perspective from the ground, at least, of what you think is not right.
Yeah, and I would say one of the challenges there is I don't work in clinic, and most of those are kind of clinic focused. And so while I have a bit more insight into some of these things than you, I'm an ER doc, so I don't. But I don't mean to judge the recommendations either. I'm just trying to sort of explore the issue.
Yeah, let me try to answer that because I think you hit on some things. We're saying you got to work smarter. And in order to work smarter, you're going to need systems to help you work smarter. And that is, and you talk about cultural change. It's got to start at the top. It's got to be leadership down to the docs. Those three things I think are important in order to understand what needs to be done in terms of culture change. First, recognize that we have an issue. Second, what are the systems in place to make it change? And third, how do we work smarter? I think early on, I said this to the consultants. I said, I don't want to drive people into the ground in terms of work. I would just want to make sure that they're working smarter in this endeavor. Stephen?
Yeah, the only other thing I would point out, and we tried to call this out in the memo, but I can't remember the figure. It might have been figure 9. It was basically a plot that showed productivity on one axis and compensation on the other, but I want to focus on the productivity. There could be, I couldn't count all the dots, but I'm thinking that there's 20 to 30% of the physicians at the UVM Health Network that are absolutely hammering it from a productivity standpoint. I mean, you can see them; they're way off to the right. So there is a percentage of docs that are really, really, shoulder to the grindstone. The problem is there are more physicians in the lower quadrant which are not performing. So the thing that we believe needs to happen is that management needs to have a consistent level of accountability for the physicians based on, their FTE, clinical FTE assignment, right? So some of the physicians are 90% clinical FTE and maybe 10% research or teaching, and others are, 80% teaching and research and only 20%. So with that adjustment, I think management has to hold the physicians accountable to the same level of productivity. And what that document showed is that, at least from a compensation standpoint, that system of holding people accountable to a baseline level of productivity is not there. And frankly, that could mean some of these people that are absolutely shoulder to the grindstone may actually need to back off a little bit, but there's a whole bunch of other physicians that need to be brought up. So we are not trying to say that this is an issue with every last physician at the health network. We are in no way saying that. The data supports that there are a percentage that are, but the management controls need to be in place because it appears that it's up to the physician's own sense of what, hard effort is what governs the work.
Yeah, I appreciate that. Okay.
there's also some tension with their academic duties that can happen, or their administrative duties. And I think A&M came to the conclusion that some of the administrative activity that is done by physicians was maybe not very well organized and inefficient. So there are other opportunities. Just reducing the administrative time perhaps might free up some more clinical time. So
Yeah,
it
I
wasn't
think
just work harder, it was just work differently.
I think there was a note that there was 13% administrative non-clinical FTE in the UVM medical group, and the benchmark was 5 to 10%. And I don't know, I think the quick back of the napkin calculation, if you dropped it from 13% to 6.5%, worked out to something like 50 FTEs, which is almost the benefit that you would get out of all the productivity improvements. But then I think we sort of have this balance. If we have low clinical productivity and we're kind of saying, well, there's culture, but there's also a lot of clinical operations. We need to improve people. We need to help people work smarter. We need to have systems for people to work smarter. Well, that's clinical admin that's gonna work to do that. So now you're saying, okay, well, we have more roles for clinical admin, but we want to shrink clinical admin. So I think we have this sort of like challenge where you have a inefficient clinical administration infrastructure that we're trying to cut to improve. I don't know. There's a circle there. I'm sorry. Go ahead, Steve.
Yeah, no, I want to point this out because A&M was very clear on this point. They actually believe that the clinical administration is overstaffed right now because of the lack of consistent process and the lack of automation and tools. There's so much one-off stuff that has to be orchestrated across these 1,000 physicians, and that work is manual. So they actually believe that a more efficient system with more standards and more automation, we could actually get a lot more done with fewer clinical these are administrative roles, let's be clear, but administrative roles focused around the clinician scheduling and follow-up. So I thought that was just noteworthy. It was not intuitive when you first hear it, but that was a point that A&M was quite strong on.
That's helpful. I'd love to have this conversation all day. I'm going to do one more, just so that I don't drive everyone else nuts. But the provider cancellation discussion I thought was really interesting, and I guess I was trying to understand what do you think this high provider cancellation rate is? What is that signaling? Is there something with the compensation structure or the scheduling structure, or that providers are doing these last minute cancellations to free up time, or is this a cultural issue? Like what is? Help me understand this issue better. From your perspective on it.
Yeah, I'll start and then Mike and Nancy jump in. We did not. The specifics of the provider compensation program was out of scope for this study. So we didn't get into it in detail, but we banged into it enough tangentially that I think we have a feel for it. And basically, while the intent of the compensation structure is that the individual physicians are either rewarded or disincented based on the number of wRVUs that they perform, in practice, that doesn't occur. They do analyze RVU work at the department level, but they don't do it at the individual physician level. So it appears, and we don't have all the data, so I want to put this big caveat on this. It appears that, whether an individual physician achieves their RVU target or not, does not seem to really impact how things flow from a compensation standpoint, as long as the department in aggregate has the right, RVU target. And that gets to the whole discussion we talked about productivity and pricing and the revenue cap and all this other stuff. So there's something that is not working well in the current system, but it was out of scope to provide you any more detail than what I just described at a high level.
But how do you, I guess with this, it was really called out about this provider cancellation rate being such a, an outlier of productivity challenges, but also, clinic disorganization, having to reschedule patients, really a patient, a patient access issue. And I guess I'm trying to say, do you have any idea why it's happening?
Let me state it differently. I do not believe, just based on the data, that if a physician was to cancel appointments and not see the number of patients that they're expected, I do not believe that has an impact on their compensation.
Okay.
And that to me seems odd, right? But again, we didn't dig into detail, but just the fact that this occurs with the frequency that occurs indicates that there's not a consequence for that.
And I would add, there's not a supervision competence there that oversees this with the systems as well.
Thank you so much. Sure, we'll have more conversations. I look forward to the implementation work and appreciate all the hard work and time and effort. I think it's a huge service for all of us. Thank you.
Thank you.
Thank you. And we're a little behind what I'd anticipated being. So just there's a lot of hospital leadership here for the next segment. Just for planning, we may have public comment. Member Holmes has a few questions. So why don't we plan 12:30 for hospital leadership on the CAW issue? So I'll turn to Member Holmes. And I did want to thank Member Holmes actually for being here. For those who don't know, she's actually in Australia and got there, I think, 2 days ago. But she thought this was a very important hearing, and I think it's about 2 a.m. over there. But I think it actually reflects her appreciation for the work that you all did and the importance of it. So Member Holmes, thank you so much for being here.
You're very welcome, and I'm happy to be here. It is 2 a.m. But I first of all, Mike, I did want to thank you for actually letting us twist your arm many months ago and get you out of retirement for this important work. And thank you, to Steve and Nancy as well. This is just really, really important, insightful work. And I also want to, give a shout out to Dr. Leffler and the leadership team for embracing this process and recognizing the need for change. I mean, I think it's really important, and the tide is turning. I guess I'm going to shorten my questions in the interest of time. Let me just ask a quick one as a follow-up. I had a question about that scatter plot, and you've answered it largely when we think about that relationship between clinical productivity and compensation and the lack thereof a relationship. And if we think about it, that creates an obvious mismatch, right, between revenues and costs. The providers are producing at 20th percentile and getting paid at the 60th percentile, for example. There's a mismatch there. So I guess my first question is, is there discussion at UVM Health now of overhauling their compensation system to tie their compensation more explicitly to productivity, as many other hospitals do in the country?
We have not had that conversation with them, but we plan to have that conversation with them, but we haven't yet.
Okay. And then the second, really, I guess I'll just leave it with this question, but I am curious, have you and the consultants looked at practice-specific comparisons of clinical productivity and wait times? For example, are there practices where the productivity is low, but the wait times are really high, such that, improving the scheduling efficiencies, increasing face time with patients, reducing admin, will increase access and better align those revenues with their costs? But are there other practices where we're seeing both low productivity and really little to no wait times, such that may mean that there's a need for right sizing of the department, that there may be actually too many providers given the patient volumes?
Stephen, do you want to take a stab at that one? It's sort of in your...
Yeah. Jessica, the short answer is I'd have to go back to A&M as to whether they broke that down to the level of specificity that you just asked for. What they did say, though, is that their belief and their number one recommendation was what they called, locking down the schedules. Basically ensuring that a clinic, sees patients from, 8 to 5 days a week, and that the providers are, filling all of those slots. They felt like that was the number one thing that would improve productivity and reduce wait time. They may have the data below that that supports that. Here's an example of a clinic that is high performing on both low wait time and high utilization, but I don't have that right in front of me.
I'm actually just I'm interested in, low productivity, relative to the national comparison, like 20th percentile productivity, but there's really no wait times, or there's very low, there's people are not waiting in line. So there's not a lot of excess demand, but there may be excess supply of providers, given that there's not a lot of productivity relative to other, practices at the national level. So it may suggest there's too much supply there, I guess, is my question.
Yeah. Nancy could probably speak to this more than I could, but there is definitely a situation where, as the medical center fulfills its academic medical center mission, it may need certain specialties in order to, attract students and do the clinical rounds and the other items, where those physicians would not be warranted if the only mission of the UVM Health Network was to see patients. So this issue of are there specialties where there are more physicians than patient demand alone would dictate? The answer to that question,
Yes.
Jessica, is yes. Yeah. How big of an issue that is?
That would be helpful to understand, because I do think, we can increase productivity if there's patient demand. But in other instances, as you just suggested, because of academic medicine, because of call schedules, because of, a whole host of reasons, how much leeway is there. It would be helpful to understand, maybe what the consultants have analyzed there. Those are my two questions. Given the time that we have, I'll leave it there. But thank you so much for coming and for all of this analysis. Hugely helpful.
Thank you very much, Jess. Thank you again for being here. I'm going to turn to Dr. Leffler. I believe Dr. Leffler is on, the CEO of UVM. And thank you for being here, Dr. Leffler.
Thank you, Chair Foster. So I want to start off by thanking the liaison team and our consultants for bringing this work forward. It's been very helpful, and I want to just say that I really appreciate the partnership of the liaison team and their guidance. We're working through some tough stuff right now. We didn't get to the situation that we're in overnight, and they've been very helpful in helping us work through some challenging circumstances. So thank you very much. I've also thought this was an amazing conversation today. Lots of good information and sharing, and really good open dialogue. So I have appreciated that. Most importantly, I want to say that UVM Health has incredible, skilled, talented providers who are here to serve the patients across our region. And the report, I do not believe, reflects that they are not doing their best to see the patients they need to see. I think in many ways, the system hasn't served them to meet their needs. And a lot of this has already come up. I just want to reinforce it. I don't think we've built the systems in place. We have a lot of one-offs and extra tasks that have to be done that requires administration. And some of the work of the system in front of us is reducing that and making sure that our providers can do what they do best, which is care for us, our families and loved ones when we need it. We are totally committed to that work. It'll be challenging. It's changing people's schedules. It's changing things that they've built their lives around. But we are committed to doing that work, and we've already started. And we've started on some clinics already on scheduling work to make the schedules be more consistent over the whole week and filled in more efficiently. I also want to say that in terms of expense reduction, we are working extremely hard on that right now. If you look at UVM Medical Center, more than $200 million of revenue came out on January 1st. For UVM Medical Center, it's impossible to bring out expenses as fast as revenue has come down for us, which puts us in a situation right now where we are losing significant money every month. It's a huge crisis for us, which we're doing our best to address. We're trying to do every step that we can. Provider productivity is one piece of that. But I would say the bigger and more important work is to make sure we're getting full, complete value out of the system. And so I heard that conversation come up. It is critical to our survival that we make the maximum efficiency, get every penny out of the system. And we're doing that work now. Also challenging work, also can't be done quickly. We've set a goal for ourselves that by October 1st of 27, so when our next budget kicks in, that we'll have 100 million of expense out. Hugely challenging. But we are committed to doing that work. We know that's critically important going forward to have us be as affordable as we can for Vermonters, to be as productive as we can so we can get as many people seen and improve access. But we have to do that while we're driving up our quality, making it better, and while we're meeting all of our other missions as well. So we're doing it, and we're going as fast as we believe we safely can without breaking things that could be hard to repair when they're done. I do strongly believe there's a path forward for healthcare in Vermont that will make it more affordable, more accessible while improving quality, but it's not easy and it can't happen quickly. And I know there's urgency to getting expenses down as much as we can, as fast as we can for our survival. We can't stay losing $15 million a month, but we're trying to do it in a way that allows us to make the expense changes in a way that works for our more important mission, which is caring for people across our region. So I really appreciate the opportunity to make comments. I've loved the discussion, and I can take questions if you like, Chair Foster, or I'm happy to stand on my statement. So whatever works for the board.
I think your statement is sufficient, and I did want to thank you for stepping into the breach. You've taken a dual role, and there's a lot coming at you and everyone else, and I'm sure your work is not easy, but thank you for taking it on, and thanks for making your comments today. I'll turn to the healthcare advocate for any comment they may have.
Good afternoon, board and liaison group. Mike Fisher here. First, just a process comment. Has there been a change that prevents me from turning on my camera? I would generally show up by turning on my camera at a moment like this, and that doesn't seem to be an option anymore. And we can address it later. I just want to recognize it.
You're as handsome as ever, Mike.
So thank you, everyone. I appreciate the conversation, and I appreciate the report. I just want to recognize that from where I sit, it has been hard to. Well, maybe that option has just been turned back up. From where I sit, it has been hard to measure the effectiveness of the liaison group over the time, and the liaison was a significant component of the UVM settlement. So it is good today to see this detailed and critical analysis of many of the internal workings at UVM. But I want to ask just a question about, I want to try and connect the dots a little bit. Today or this week, across the way over at the State House, there is a discussion about reducing spending, reducing prices in the range of maybe $50 or $75 million at the PPS hospitals, and at this for FY27, and then I see your recommendation of reducing costs at UVM of $100 million in each of the next 3 years, starting in FY27. And I'm just trying to connect the dots. Of course, reducing costs without reducing prices doesn't have the results that the liaison team spoke so clearly about, improving access, affordability, and access for Vermonters. And so, do you have a comment about that, or have you thought about that at all?
I'm trying to connect the dot to your question here, Mike, but let me try on this one. We have not followed legislation that's going on in the State House in terms of what is happening, because it changes so dramatically from day to day. We did follow and put into our analysis H1, which is law, federal law now. So we did that analysis. We looked at Medicaid and Medicare and what is going on in commercial rates. You know, we made an assumption that there wouldn't be growth in that area, and we put in, you know, last year's changes into the analysis. But we have not followed or contemplated what is happening at the State House in this analysis.
So I want to recognize that UVM. Yes, Steve.
Yeah, I was going to say the only comment I would make, Mike, and this gets to the point that Mike made in his opening remarks about just, coordination and things with the transformation effort. There's activities that we've been looking at, and effectively, just to highlight for everybody, commercial revenue is basically going to be flat for the health network between now and 2030, according to the most likely scenario in the budget forecast that they did, which means that any increase in utilization would be offset by a price decrease. That was sort of the baseline. How that translates into dollars, we can forecast. But my main point is, we've had our work, the care board's doing its work, the insurers are doing some things, and the legislatures are doing others. When you talk to people, some people talk percentages, some people talk dollars, some people talk revenue, some people talk expenses. And, we've done our best to try to stay on top of the various things, but it does feel a little chaotic in terms of the entities that are coming at this problem and the approach with which they're coming. And Mike, I believe I am speaking for liaison team B, the state would be well served for a little more coordination. And ultimately, and maybe it falls back to the insurers, something that says, if we want to keep premiums to this level, here is how much cost needs to come out of the system. Once we know what the cost is, we can decide how that should be shared by the various entities, and whether, a QHP price cap or a broad price cap or some other mechanism is appropriate. But it feels, your question is a good one, because to us, it feels a little chaotic. And that's the main point I want to make.
Yeah, thank you. I think this moment feels chaotic to many of us. And so maybe it's just an opportunity to do a shout out. 2027 is going to be an odd year. I think we are all, I think many of us are hopeful that 28 and beyond is, we can have a process that's driven by board rule and, and public discussion about what's the right amount to reduce prices going beyond. Okay, thank you. I maybe just one other. I note that I didn't hear any discussion in this report, and I can't track whether there has been in previous ones, about the New York hospitals. And I know that's been a point of real discussion. And I wonder if you have any comment about how the New York hospitals expenditures play into this.
Yeah, it was in a previous report. We talked about the fact that there needs to be a repayment plan.
Yeah. Okay, thank you very much. Appreciate the work.
Okay.
And the only other comment I would make on the Vermont hospitals is that they were losing serious money in years past. There has been a process that the health network has taken to right size their financial situation. So I don't believe that they're completely self-sufficient at this point, but they are in significantly better financial health in 2026 than they have been in years past. So I want to call that out, because that is an improvement that the network has put in place.
And you're talking about the New York hospitals, Stephen. You said the Vermont hospitals, but you're talking about.
I'm sorry pardon me. New York hospitals. Let me be clear. New York hospitals.
Maybe Mr. Chair, I'll just make a final comment about the connecting the dots discussion from a minute ago. I don't believe any of us would be looking for a scenario where we reduced UVM's expenditures significantly more than we pulled prices out for consumers, reduced premiums, resulting in, it's hard for me to believe that anyone would be after reducing, resulting in, more reserves or profitability. I'm assuming that we're all rowing in the same direction of having a direct result on improving access for Vermonters. So I appreciate the comment about how hard it is to be planful at this moment. but I'm going to believe that we're all rowing in the same direction on that.
Mhm.
Thank you, Mike. And, I'll just note, it's 4 years since Act 167 was passed because we did not want to be in a chaotic situation. That bill was passed and signed by the governor in 2022. And in his letter signing it, he recognized that this was an extremely risky and volatile market with serious headwinds coming at us. So we have had 4 years to plan and address this chaotic moment, and we need to get to action. And that takes hospitals, non-hospitals, AHS, Care Board, DFR, UVM, everybody. We're at the moment, and if not, delayed. I'll turn to public comment via raise the hand. Great, hearing none. Many thanks to the liaison team. Oh, hang on, I got one. Walter, how are you?
Hey, Owen. Again, my camera won't turn on, but I've had other members of the board, like specifically Dave, have already said my concerns. But we've heard a lot of talk about patient experience. And I come from the point of view of being a patient. And one of the things that drives me crazy is when you think everyone's talking about sources of revenue. The patient is the source of revenue. They're called consumers. And patient experience when you go into a hospital can sometimes be almost demeaning. It's like a machine, an assembly line. That's one thing. Another thing is Stephen brought it up, Blue Cross Blue Shield high rates. There, many years ago in 23, for example, I had a gallbladder surgery the same day George Bush invaded Iraq. And I got out and I got my copay. My copay went up $200. It went from 50 to 250. And I called up Blue Cross and I said, hey, what's going on? They said, well, our prices go up, so we got to bill you more. And I said, well, my wages don't go up. And they say, well, we're sorry, but it's a bummer to be you. So when you think about this, the patient is not only the resource for economics, but they're also the victims of this. We get surprise charges. We have to deal with so much like that. Suddenly the costs raise, the copay, the deductibles raise. And then you talk about administration fees or administration costs. We all know that. So overall, I am wondering if the liaison group would recommend that, say, the care board or an entity have more regulatory power, because it was in the same year 2020 of 23 when they raised my price, when they raised my deductible, that Blue Cross paid a CEO a golden parachute of like $6.25 million. And this is what's going on in the system for us. We talk about access, cost. All of these cost drivers are just pricing us way out. So I'm wondering if there's something someone can do to make sure all these recommendations not only be recommended, but get implemented and then watched. And I think of, sinful unwatched UVM, sinful unwatched BCBS. Somebody's got to watch these people. Otherwise, it's just going to go right back to the same old thing.
Thank you, Walter. Appreciate you coming in your comment. I'll just note, I think that bonus number was not a Vermont bonus number, just so that people are not confused. I don't think any Blue Cross Vermont executive has ever seen that kind of payment. And we have been critical of executive comp at the ACO, at the network, and at Blue Cross, but that is not a number that I've seen in Vermont. And it is our job to, as a regulator, to watch and observe and make sure that we're catching the kinds of things you're concerned about. And we try hard to do so. And I think we do a pretty good job. And we will be holding UVM accountable to implementing these changes as effectively as possible. Perhaps they're ambitious, but they're necessary. And I think we have a time where we can accomplish that. I'm watching a time, and I think we don't have any other public comment. So I'll just thank Ms. Kane, Mr. Gorman, and Mr. Smith very, very much for your work and continued collaboration with the board, the public, and UVM. We're going to take a 3-minute break, and we'll come back right around 12:30 for the critical access hospital work group meetings. And Mike and your team, please welcome to stay if you'd like. But otherwise, thank you all very, very much. Good to see you all.
Thank you.
Okay, we can resume our hearing of May 13th. We'll next be turning to the Medicare critical access hospital cost sharing issue. The board and hospitals, critical access hospitals have been engaged in. I'll turn to our Director of Policy, Elena Barabee, to lead the discussion along with Kirk Williamson. Steve.
Great.
Thanks,
Can
Elena.
you all see our screen?
Yes.
Okay. So this is, I think, one of 3 now presentations. This is just a little history. We have been speaking about this topic for a couple of months now, and have had some back and forth with hospitals. So this is to kind of review what we've heard, what we've learned, and give you some considerations for next steps and paths forward. So just briefly, the problem. So as we understand it, patient cost sharing, again, this came to us through a public comment. We were trying to understand why some Vermonters have much higher bills than others, even though they're getting the same services. And those that go to critical access hospitals tend to have these higher priced or patient cost share. So the problem that we've discovered is the patient cost sharing in critical access hospitals is calculated off of charges, which are often much higher than the Medicare rate. So at PPS hospitals or other non-critical access hospitals, patients pay 20% of the Medicare approved rate, or the amount that the hospital actually receives, up to a certain cap. Whereas critical access hospitals, this cost share is uncapped, and that is translated into patient out-of-pocket costs. And that means that for some claims, Medicare pays absolutely nothing, and the patient pays the whole bill. And that is not the case when patients receive care at a PPS hospital. And this kind of has ripple effects, and we won't go into much detail, but we've talked about kind of the implications for secondary payers. It's not just out-of-pocket costs, but if patients have Medigap or Medicaid, these have certainly additional impacts across the system. This is just an example, a hypothetical example of the same procedure, same Medicare coverage, but a very different experience in terms of the patient's bill. So on the left, you'll see a patient going to kind of their general community hospital paid on the OPPS payment system, would have a bill around $12,000. Their co-insurance would be around 20%, but it would be capped at that $1,676. So the effective patient share, if you look at kind of what the patient owes relative to Medicare, is only around 13%. A comparable service at a critical access hospital, because they're cost plus, the hospital may bring in more, but the hospital charge itself could be much higher, and it could be at $31,500. If the patient pays 20% of that high charge or that list price, it goes up to $6,300. And with no cap, the patient would be liable for that $6,300, or in this hypothetical scenario, 48%. So this is a very traditional kind of example and comparison that exists not just in Vermont, but any state where patients are accessing care at critical access hospitals. So some other digging that we've done since then was really just to understand, the other kind of pieces of this puzzle. So the, charges being one major component of why patients are paying higher prices or have a higher cost share in these settings. If you can see, we just started looking at Vermont kind of over time to get some idea of trend. This compares Vermont to the national average using Medicare cost share or cost report data from the NASHP cost tool. So the purple line is the national trend, and you can see it's kind of gradually coming down. The Vermont trend line is also coming down, and what this suggests that, both in Vermont and at the national level, we see that charges are diverging from costs over time. That is one piece to this puzzle. If you dig one layer down, this is a ratio. So is it charges or is it costs? It could be costs going down, but it could also be charges going up. And so what we see here, looking at Vermont only, is that hospital operating costs have gone up slightly, but hospital charges have really skyrocketed between 2011 and 2024. So what's driving some of this cost share is not just this Medicare rule, but is really the growth in hospital charges over time. And so that last number I showed you is total aggregate charges. So someone could say, you know, oh, well, that's just because we're doing quite a bit more volume. And I think, you know, if we build on the last conversation we have, that is not the case in Vermont. And if you look, this is just one measure of volume. This is adjusted patient discharges, holds pretty flat over time. So it's not kind of analogous to the kinds of growth that we've seen. So really this growth in charges observed on the prior slide is really most likely due to increase in the charge master or the list price that hospitals are billing. So the root cause, as I mentioned, is really, you know, yes, the CMS rule governing the critical access hospital reimbursements that ties the patient share to hospital charges. And that's really important and is something that we've been exploring with our federal partners, which I'll explain more in a minute. But, you know, it's really also hospitals setting charge masters that may be artificially high, and that is certainly worth exploring. So we wanted to point to kind of some relevant laws and regulations that are kind of guiding how we're thinking about possible policy solutions. Certainly this is one that has come up, but ensuring, you know, per Vermont law, that financing of healthcare in Vermont is sufficient, fair, predictable, transparent, sustainable, and shared equitably. You know, I think there's another reference that's important to consider. I believe this came from the CMS letter that Vaz recently shared with us as it relates to charges and this concept, like, are charges appropriate and you know, reflective of the costs. So here, per federal law, charges are defined as the regular rates for services that are billed to both beneficiaries and other patients. Implicit in the use of charges within the Medicare program is the expectation that such charges bear a reasonable relationship to the cost of furnishing services, as charges are used as a proxy for costs in various payment and cost apportionment methodologies. So we thought this was a really important concept just to make sure that you were aware of, and we keep bringing forward as we're thinking about both kind of the Vermont law and the conditions of the federal law that govern how much patients pay and how this is all kind of coming to a head. So in the next series of slides, I just wanted to remind folks of the information that we've requested from hospitals, what they've shared with us, what we've learned. We have both reflecting on the first letter we sent on February 18th. I'll kind of reiterate briefly what we discussed. I won't rehash the whole hearing from March 24th, but highlight some questions that you all asked there. And then we issued a follow-up letter to hospitals to ensure that everyone was aware and clear on the questions we were asking in the hearing. And so I will kind of walk through what we have from hospitals on those questions as well. And for everyone's awareness, all of the back and forth letters and responses and various, you know, important components of this conversation are all shared on our website at the following link, so you can find them in more detail there. So the first letter we sent asked kind of 4 key questions. So we asked hospitals to identify and describe the amounts of their charge masters that exceed the fee-for-service Medicare payment amounts. You know, we clarified this, I think, later to ensure that hospitals we're talking about your cost-based reimbursement. We're not asking you to compare to a different, method, but really how different are your charges from what you're actually paid by Medicare. We wanted them to calculate the difference in cost sharing for their patients in 25 and kind of help us understand the difference in cost sharing across their patients in specific categories. We asked them to calculate the impact to their hospital's revenue if the charges were reduced to their Medicare payment amount. And then we asked for their input on potential solutions to this problem. We outlined a few that we had thought of that might move the needle in a more direct way, but asked them to kind of help us understand what they thought and if there were other options that should be put on the table. The information we received in this first round was, not super detailed. There was a lot of, we can't calculate this, or, this would break the bank, but not a lot of kind of deep thinking on how we could solve the problem. I think hospitals pointed to a federal solution, but didn't really highlight any state solutions for us to consider. And I think we reviewed this in our last hearing, so I won't spend too much time here. But in our hearing, the goal was really to kind of push on these questions further. We covered a number of topics. This goes on to the second slide, but we were interested in understanding the compliance risks that were cited by hospitals, impact to Medicare revenue. Again, we asked commercial side impact barriers if charge masters were reduced. So I think one of the major threads is, hiccups is that if we were to reduce charges, or hospitals were to reduce charges, that their commercial contracts would shrink as a result. But that's really because of the way some of their contracts are structured as a discount off of charges. And it's not to say that they couldn't restructure those, but I think a lot of the, unwinding all these assumptions is going to be really important for quantifying, what the impacts could be or are, and for certain or not. We talked with insurers about payment structure and contract negotiations. I think we learned that most hospital contracts have not been renegotiated in many, many, many years. And I think that is kind of one area that was quite surprising to us. So is perhaps why we still have a lot of legacy pricing structure in our state and in these hospitals. I think there were a lot of follow-up questions we had to hospitals in this hearing, so I won't, again, list out each an individual one, but I think, we were hoping that hospitals would follow up, and I think, the board really highlighted that these questions were out there, and if they were unanswered, we would expect follow-up and further discussion. In that light, we issued a second letter just recently and received responses, I believe, last week, and have been working with hospitals. There were quite a few confidentiality requests. This letter really underscored kind of the priorities, questions that arose from the hearing, and included kind of a revisiting of the federal compliance risks. And as I mentioned, we received response from VAS, and they shared some other kind of legal information with us on that topic, which was enlightening. And then again, trying to revisit the total impact on their Medicare revenue. I think, one thing to keep in mind is some of the assumptions that go into these calculations are really important, and assumptions around renegotiation and whether or not you're able to renegotiate as a discount off of charges, for example, and let's see, and the proportion of commercial revenue as well. So I'll leave this here. Again, I'm not going to read each line to you, but it's here for further reflection if you'd like to kind of understand the high-level responses from hospitals. Actually, I should say one more thing. I think the last thing is we have, and I think Kirk will talk a little bit more about some of these strategies, but, if we're not going to, or if, one strategy is to dig into charges, another strategy is around kind of financial transparency and financial assistance. And, we heard that hospitals were interested in exploring this and we're open to it, but we have not yet heard kind of a formal solution or formal proposal from hospitals on how they would think about doing this. So I think that's another avenue that, requires additional follow-up. So again, we've been exploring solutions. I'll just remind folks of the federal solution and kind of what we've been doing on that front. We've reached out to our federal delegation, actually a number of times on this issue, as well as other national organizations and experts who may have an interest in this topic. We understand based on some older data, and this is probably, this number has probably only grown since then, that we would need to, the federal government would need to find $3.2 billion annually to plug this gap and keep critical access hospitals whole while reducing patient cost share to a reasonable amount. And we've been exploring other states who may have an interest and could work with us on trying to drive forward a federal solution. But, given our current environment, there's not a whole lot of extra money we expect to be floating around for this purpose, but it's certainly an angle that we are pursuing heavily. We also continue to explore, possible state solutions on this topic. I won't rehash this as a slide from a previous presentation. We put on the table reducing hospital charges to, the cost-based reimbursement that hospitals receive, reducing to the OPPS equivalent, which would really create parity across hospitals and patient experience, and then capping patient cost sharing, which I think we explored and learned that's really, not an avenue we can pursue, but really A and B were areas that would be kind of on the table or could legally explore. But I wanted to kind of step back before going further and talk about kind of two distinct ways that we've been thinking about this issue. I think it's important to keep in mind. So, you can directly intervene by reducing charges or normalizing charges, and because charges are supposed to be correlated with costs, there may be room here to bring our charges more in line with costs, and that would, support kind of CMS's approach to charge and the cost to charge ratio and related constructs, but this would result in lower patient cost share and would result in a dollar for dollar decrease in the amount that patients would be responsible for. The indirect intervention takes charges as given potentially, but creates patient protections through either increasing transparency. If patients are able to access this information at the time that they're, making decisions about care, which is not always possible, it may allow them an opportunity to consider their options. They would, having all the information in one place is kind of the tricky part, and making sure that the information that patients receive can actually inform their decisions is not super easy, and no one hospital really has all the information to do that on their own. They could strengthen their financial assistance policies. I think we heard some of them kind of say they've kind of done what they can do, and this would be challenging at a payer level, but we may have some other ideas there as well. Or we could expand medical debt protections. This is something other states have done, and Kirk will talk a little bit more about in a minute. So again, I won't direct intervention is kind of where we started and what we've been talking about. I certainly think there is an avenue to keep thinking about how we might bring charges in line with costs. And, you could also think about setting limits on cost to charge ratio or within a range. And then I just wanted to remind folks that if hospitals are going to be moving to contract on the basis of Medicare and moving away from a discount off of charges, this should actually support some of the charge, normalization that we're asking them to do or think about doing, while preventing unanticipated erosion of commercial revenues, which was I think the #1 issue that was cited in some of their concerns with the direct intervention strategy. And this kind of contracting is already required under S190, which is still not a done deal in the legislature, but is also required in order for us to implement reference-based pricing. So if we're going to be moving all prices on the basis of Medicare, moving contracts on the basis of Medicare is also critical to making that effective. So I'm going to pass it over to Kirk, who's been digging into direct intervention and can bring us home.
Great. Thank you, Elena. Hi, everybody. I'm Kirk Williamson. For those who don't know, I'm the Affordability and Pricing Project Director. So these next few slides, we'll talk on some of the indirect interventions that perhaps you all could consider maybe as a complement to the direct intervention. We took a look at some other states to kind of learn what they are doing, maybe not directly analogous to the cost sharing issue, but we think could be applied here. So one is around increasing transparency. Connecticut and Florida, they actually require the disclosure that a facility fee may make care more expensive than other sites. And actually Oregon, they leverage physician referral. So they require that a provider informs the patient that they could receive the same care at a different facility without any retaliation for that, and to work with their insured to understand the coverage and cost of care. So this is about helping patients understand the price differentials between different settings. And so in Vermont, as Voz has noted, they're working on this in a manner and format that we would approve. Elena made mention to S190 that as drafted, it would move hospitals towards contracting as a percentage of Medicare. And in Vermont, we currently have no direct patient notification requirement or any mandate of a revealing of the price or a price differentials at the point of scheduling the site of service or upon referral. So that's one avenue to explore. Next slide, please. So the next bucket, the second bucket is in financial assistance policy, and I believe several hospitals in their responses alluded to financial assistance policies as one avenue, but they weren't very detailed in what that could look like. So just a reminder that here in Vermont, we do have quite a comprehensive, uniform, statewide financial assistance policy. In many ways, it is more generous than in other states, but we would note that several gaps remain, and that they could be helpful, particularly here, in dealing with this cost-sharing issue. The first is around a presumptive eligibility requirement or automatically screening patients for qualifying for financial assistance. So the example we provide is from Oregon. They require presumptive eligibility screening. This would require hospitals to affirmatively screen uninsured patients and then any insured patient with a bill above $1,500 for financial assistance before sending a bill. Another option to explore is a patient liability tied to a benchmark, and that dovetails well with where we're going on reference-based pricing. New Jersey caps the amount a hospital may bill an insured a New Jersey resident, and they do this at 500% or below the federal poverty level, and it's keyed to Medicare. New York has a similar model that I didn't list here, but they actually tie it to the Medicaid rate. And then the third bucket is this catastrophic or a hardship tier that would bill as a percentage of income rather than just having these income tiers people can qualify within. So in New Jersey, they actually cover full charges when a patient's medical bills exceed 30% of gross annual income. And then New York, they cap the total annual hospital liability at 5% of gross family income for those patients that qualify. So next slide, please. In this last bucket of like indirect intervention, and again, indirect meaning we are not directly intervening on price, but these are solutions that could help still provide relief to Vermonters and to vulnerable seniors. We have medical debt protections on the books from 2022 and in 2025. Again, we did a scan and noted that many gaps still remain that you all may consider, whether that's through regulatory action or through recommendations to the legislature, some being a wage garnishment ban. Several states also prohibit property liens taken out for medical debt, ban on lawsuits for those below an income threshold, ban on transferring medical debt to spouses, and a ban on denying care. And this is really around those egregious collective actions. So this would help protect those seniors that may have large medical debt resulting from their cost sharing requirements due to the bills that are charged at critical access hospitals. Next slide, please. Voz mentioned the compliance letter, and you all have read it. There was also a letter written back from CMS to Voz that highlighted possible hospital actions that actually dovetail nicely with both the direct and indirect interventions that Elena and I have discussed today. The first, really instructing hospitals to review and rationalize their charge master rates. The second is really around increasing transparency to help beneficiaries understand what their cost sharing obligations may be in advance of receiving a bill. And then the third is to implement individualized financial hardship programs. The OIG has a set of FAQs for waiving or reducing cost sharing on a case-by-case basis that would not violate the anti-kickback statute. Next slide, please. So as for possible next steps, one is to consider executive sessions to discuss confidential information on commercial contracting. Elena noted earlier in the discussion, each hospital did have sections of their second letter that requested all that information be confidential. And so if you all wanted to discuss commercial contracting with each hospital, we could think about what that would look like as a series of executive sessions. Another next step could be we consider the hospital's proposed submissions or solutions, ask them for concrete solutions that they would agree to before June 5th, and then we propose having a final working group hearing on June 15th. Next slide, please. And I think that's all we have. Chair Foster, I'll turn it over to you to lead the discussion.
Thank you. And this is somewhat of an informal discussion as we frame these as a work group session across different stakeholders. So not a normal board process necessarily. I want to, recognize and thank VAWS and the critical access hospitals for providing us a lot of information and for digging into this issue. In their letters, they recognize the importance of this, and they provide us a lot of substantive information that is important to whether or not we take regulatory action or the hospitals are able to find a path, or if there's no path available at this time, we need to explore these issues so that we can do it. So I want to thank the hospitals for that. And also I wanted to comment on their commitment to transparency. There was a rural caucus hearing that I participated in, and in these letters, there's again a commitment to transparency to the patients. So I want to recognize that VAWS and the hospitals are stepping up, that they agree with that and that they're willing to do that. And it's not just necessarily a push and pull back and forth between the regulator and the regulated. And I think that's important here. What we are trying to do is ensure that the hospitals do not have a financial loss from this. And yet at the same time, we're trying to ensure patients are not inappropriately paying more than they need to. And so that is the goal. We do not want to see a critical access hospital harmed financially, and we also don't want to see patients harmed financially. So I want to thank everyone for the work on this and our staff for digging in. It is an important issue. Mr. Del Trecco, I see you came off, your camera came on, so I'll open up to you and your members if you have any comments you want to make before we kind of just open it up to discussion.
Sure. Thank you. I think the highlight that Elena went through included many of the things that were our potential options. I think there are a couple of items in the CMS letter that I want to bring forward to be mindful that there's other issues that are potentially, and then focus on another area. When the citation around that we, around charges, there's a specific section in the letter, page 2, where it says, however, in light of the statutory and regulatory framework described above, and that was around the hospital charge structures around reasonable cost, there are significant federal constraints to state action in this area. I mention that not as a barrier, but as something we need to address and recognize as we move forward. So 3 areas, as we've spoken about before. If a state requires critical access hospitals to modify its revenue cycle practices or charges for services provided to Medicare beneficiaries with the intent of influencing Medicare reimbursement or altering beneficiary cost sharing amounts, those hospitals could face federal compliance. The issue here is the hospitals face that. We bear the risk and we don't know the outcomes. Part of it's tied to artificially reducing charges, anti-kickback, and false claims. Again, not to say there's an issue or we've done something wrong. We just need to acknowledge that as we move forward and explore these items. There's also a section that is spoken to that includes 5 components that we could that are available to stakeholders as options. As mentioned, the first one is congressional and legislative action. I know that the Green Mountain Care Board, as well as VAWS, has reached out to delegation. I'm not sure if the letter from VAWS is posted on your website or not. It may be, but we are all on the same page there. And we also acknowledged that the federal requirement or federal action might not happen quickly. And that is a problem. The second is to provide comment related to outpatient prospective rules. That happens in July, and we will do that. We will make certain to do that. The third is hospital voluntary action. and hospitals may voluntarily implement financial hardship programs that the OIG would rule and waive on, and that's something we will look into. And I think it's been mentioned as an indirect component. The second is to review and rationalize charge masters. There's been a lot of discussion of what rational means, as you might suspect, and I think that will be harder to examine, and up to each individual hospital to voluntarily consider. And then I think on the transparency piece, we are completely all in. We have a template. I was going to share that, but I did not share it because I wanted to wait till S190 is complete so we could include all of the components instead of wordsmithing or editing something that was not complete. And certainly our hospitals work with individuals in their organizations around Medicare supplemental and then the state Medicaid low assistance programs. Those were 5 areas that are looked at. As far as the items that Kirk went through on the last page around debt, I don't believe any of our organizations do liens or any of those things. I wouldn't be opposed to those items, and I think we would just need to look through those things more completely. And then the last thing I will comment on is Elena's reference to critical access hospitals moving to reference-based pricing and or global budgets. I actually think that is the best pathway forward. It actually accomplishes the goal, takes intent on changing charges and or co-sharing amounts out of why are we doing this out of question. It's part of our move towards reference-based pricing and global budgets under Act 68. So I know that our hospitals are here on the call, and I'm sure many have comments to share and add. So, and before I stop there, I will say that many of our organizations, and I thank you for acknowledging this, Elena and team here, are really concerned about the sort of the unintended consequences of changing charges. There's been a lot of reasons why charges have increased over the years. One of which is the pure nature of a critical access hospital. They are inefficient. They are acknowledged and recognized by this critical access status. And part of the other parts of the reasons are some state policies that have driven pricing higher on the side of the commercial. One of those is our provider tax. It is a burden on our hospitals, and particularly our critical access hospitals. I'm not saying it doesn't create a positive situation for the state, but it's a burden on our hospitals. So there's a lot of things to consider as we move forward, and willing to do that. So I'll stop there, and thank you for the opportunity. Appreciate it.
Yeah, thank you. There's a number of CEOs I think that are here, so I'll just open up if any hospital leadership wants to comment at this time, or we can just kind of get into a free-flowing discussion. All right, well, we do that. A couple questions, and thank you for the letters that you provided us. One of the questions I had, what I'm struggling with is this notion in the CMS letter and the VAS letter about, quote, artificially decreasing charge masters. And I guess what I'm trying to understand is what would be artificial about decreasing them? And then what's the distinction between artificially reducing them and, as CMS says, rationalizing them? Where's the line between artificially reducing and rationalizing?
Owen, I think that's part of the problem. And we don't know. And that's what one of the bigger concerns is around some of these ramifications around item on page 2, where the CMS identifies all the things that hospitals could be risk at. That is part of the single largest issue of we don't know. And some of our hospitals might say our charges are rational. They help us provide services to our communities that we couldn't otherwise do because of payer mix and or some of the policy change discussions, things that I would put forward. the other important thing is that each one of our hospitals go through a pretty extensive Medicare cost report audit every year that looks at charges and relationship to allowable costs. And that's pretty intense. And that is a significant part of what is done annually. So I think you ask a great question. And I think the problem is there's no clarity to having an answer to it.
So if Medicare, I mean, I think we all agree Medicare intends and likely does pay the appropriate reasonable cost of the care on a call. That's the intent. That's why you have the cost reports. That's how they come up with the amount that they pay cause. That is, I guess, the best estimate of a reasonable cost that we have. Now, if the charge master is a multiple of that amount, how could we deem it a reasonable charge? I.e., if Medicare is paying the reasonable cost, how can it be that a higher inflated charge master reflects a reasonable cost?
I wish I had a different answer than my answer previously, but it's uncertain to me.
Okay. And the person who sent you the CMS letter, I don't know what their role is exactly. It says Health Insurance Specialist, Innovation and Financial Management. I've done a lot of anti-kickback statute cases and FCA cases. I mean, for over 12 years and to this day, I represent whistleblowers in False Claims Act and AKS cases, some of the most complex and largest that we've done. I don't understand the legal bases here. I mean, the anti-kickback statute is an intent-based statute. And if the intent is to align charge masters to reflect appropriate charges, that doesn't get into AKS concerns from where I stand. And likewise in the FCA, what I don't understand is what would be false. You have to make a claim to the federal government or Medicaid that is false. And I don't understand what would be false if we were to rationalize the charge master. I realize the letters didn't get into the detail on that, but I guess I'm just saying from having done many of these cases, I don't understand the concerns that are raised. I know you guys aren't FCA lawyers or AKS lawyers, but if there's more you want to share on that now or later, I would definitely be willing to engage and understand a little bit more on those concerns. Mr. Wooden, I see your hand is up.
Yes, thanks. I apologize if I'm just going back to basics. I'm just trying to understand things. I do love data. So on page 4 of the presentation, we've got a general community hospital comparison of Medicare rate with the critical access hospital rate. And I was always under the impression that critical access hospital rates are much less than the PPS rates, particularly given the report from March, I think Brown University report, but most of the critical access hospital rates are much less than the Medicare rates by a lot. So to sort of come up with an example where the critical access hospital rate is 2.5 times higher than the general community hospital seems a little bit odd to me. Am I getting that right? Or is it true that, at least in the chart I'm looking at, 6 of the 7 listed are all less expensive, but I'm just wondering about that. So Elena, if you could fill me in, that'd be great.
Yeah, I'm happy to. Are you seeing my, I don't know what I'm sharing now.
Discussion.
Oh,
I see it.
Stop sharing, share. Sorry, I will share that so we're all talking about the same thing.
Yep, thanks.
Okay. This is just to highlight what patients are paying. So you'll notice this
Elena,
is the Medicare rate.
I'm seeing discussion, the discussion slide, not slide 4.
Oh, hold on. I don't know why it's showing the discussion slide. Let's try this again.
Can I give a comment on that while you're seeing it up?
Yeah, please.
So, Joe, I think the MedPAC report at least refers to national data, not Vermont data. But on average, nationally, an outpatient service at a critical access hospital has a total Medicare payment that's twice a PPS hospital. The inpatient service is about the same. Nationally, the average charge at a critical access hospital would be 5 times that critical access hospital payment amount. So that's from that PAC report. You can look at it. It's the 2025 report, chapter 7. They go into a lot of detail on that.
Yeah. I'm just trying to understand if we're looking at Vermont hospitals in future data that I'm going to talk about in a minute. I didn't know this one was just sort of nationally because our critical access hospital charges are significantly less than the general community hospitals. And so this is like a wild example that swings completely not like Vermont. So I just wanted to confirm that. That's okay.
I can't. Right. So this is really, I think, comparing the hospital charge on the right to the Medicare payment rate on the left. So they're not comparable because the basis on which patients are paid is different. So that was what we were trying to highlight. So it could be that the Medicare rate is the same in both cases. This is illustrative, and the charge is, is the charge ever less than what you're paid?
When you're making mistakes, yes.
Okay, well, in reality, it's not, right? So I think that's why we're here. So this is not, this doesn't contradict what you're saying. I think what we're saying is this is the patient perspective. So the critical access hospital on the right is highlighting the charge, where the left is the rate, and those are not the same thing.
No, not at all. So the one on the left is actually the payment, and the one on the right is the charge, correct?
Exactly. Right?
Okay.
Yep.
It's sort of a little bit of apples and oranges there, but certainly the critical access hospitals charges are a lot less. If you go to the next page on 5, when you have those two lines, national and Vermont, the national line on page 5, is that
hang on,
all?
Joe, hang on 1 second. Elena, I think you're trying to say something. Did you have something else to say?
Yeah. I mean, I think all I was trying to say here is this is really not about what hospitals get paid. We're trying to hold that constant in this example and really show that there's a difference in what patients are paying. So patients are paying more of the bill at critical access hospitals than they are when they go to a PPS hospital. That's really the point. So Joe, I think what hospitals are getting paid is not part of this equation, and it could be that, it is a little less, but the patients are having to pay a larger proportion of that, and that's really the problem here.
The patients that don't have Medigap coverage, correct? Not all the patients.
And patients with Medigap coverage, I mean, their Medigap are paying this 48%. So their Medigap is paying 3 times or 4 times or however many times what they would have paid at a PPS hospital. So someone's got to pay that bill, and I think that's the point that we're making here.
Yeah. Thank you. On the next slide, though, the national versus Vermont cost to charge ratio, is that Vermont critical access hospitals? Because the labels.
This is aggregate. This is aggregate, yes.
So it's all hospitals in Vermont, not critical access hospitals.
Yes.
Okay. And then it's just national, all hospitals. So we're not distinguishing. Could we not distinguish critical access hospitals if that's the discussion on the table?
Not in the tool that we had access to, but that's something that we can continue digging into and is kind of on our list of next steps.
Okay, so page 6 is the same thing. It's total hospital charges throughout the country versus hospital operating costs throughout the country. But
this is just Vermont. This is just Vermont.
So but there's no distinction between the CAH hospitals. You're just throwing them all into one, correct?
Yes, we were talking about Vermont as a state. This is the tool that was available to us. So it's what we have, and yes.
Yeah,
I'm just digging into it further.
Yeah, I'm just wondering why we would make that distinction, because this is a CAH problem. And so there is a big difference if you look at some of the data between the CAH hospitals and the rest. And of course, UVM dwarfs, so whatever they're doing, if you do it. So,
Can I ask a question on that? Do we have any, not you necessarily, Mr. Wooden, but maybe Vaz or Elena or you, do we have a sense of whether or not the PPS hospital charge masters are increasing at a rate significantly divergent from the critical access hospitals?
I think the only thing that I'll try to answer that. I think the only thing that we would have consistently to point to is maybe the Green Mountain Care Board and prior regulatory entities rate increases from the prior years from the years and what those were. I that's just a thought that came to my head when the question was asked. That may be the best place. I'm not sure.
I wonder if we could, I mean, we could certainly ask the PPS hospitals, what if your charge masters, how much have they increased over the last 5 years, and then compare it to the cost to get a sense of Mr. Wooden's point as whether or not this is misleading in that it has the critical access and the PPS combined. And maybe it's actually worse for the PPS hospital, or maybe it's worse for the cause. And I guess that's your point.
Yeah, which is okay. It's just we really want to understand the data. And it's not necessarily the rate of increase, Owen, each year. It's actually the actual cost, because one hospital charges $10 and they get a 10% increase. It's only $1. Another hospital charges $100 and gets a 5% increase. It's $5. So we do need to look at both the rate of increase, but also the exact numbers of the charges. Both of those I think are relevant.
And it also matters where we're putting the charge increases, right? Are we putting it on orthopedics, or are we putting it on maternal services? So if we're putting it on high dollar, large volume services, it's only going to contribute that much more to the growth in the cost share. So. Okay.
And again, on page 7, the two charts are both national. Every single hospital, as well as Vermont, just combined for median adjusted patient discharge. And we don't, be nice to know the difference between sort of at least CAHs either nationally and CAHs locally, just because when I'm looking at data, I try to understand how much of it reflects us. But thank you for listening to the questions. Thanks. It's helpful. Appreciate it.
Member Merman?
I've had a chance to look at some of the MedPAC report and some of the data on the Medicare cost reports and this stuff. And I think what's interesting to me, Joe, and I'll give it to Elena and she can sort of make sure it's up to snuff. But the take home point to me on it is that the charge increases and the charge rates are highly variable among critical access hospitals in Vermont, among inpatient and outpatient, that I don't see much of a relationship between charges and payments. And payments at a critical access hospital are costs. So charge to cost doesn't show a relationship. And I think that's kind of part of your point, is that these things are all over the place and have been done for different reasons for different times. I would I think that's kind of one of the most interesting insights. And I guess the question that I would have for you is, do you think your charges are a reasonable proxy for your costs?
Well, it goes back to, I just want to say two things.
And I think Jeff, also include this on that at a service level, not at an aggregate level.
Yeah, I think going back to your earlier comment, we've always presented to the Green Mountain Care Board our charges compared to others, all of them masked, so that you can see Vermont average and what we're charging. And that question about, is this really a good surrogate for the payment? Jeff Hebert for 2 years, I don't know if it was last year, the past 2 years, Jeff has shown the actual payment commercially to the hospitals, which he has access to that data. Jeff does, it's great. And it did show they correlate really closely. So if you're wondering about, do those actually correlate with payment? I think Jeff's data, which you guys have seen over the past few years, in addition to not just the prices, charges, rates, but also what you get.
We're talking about Medicare in this environment, and so you're talking about a commercial payment. So the charge relates to commercial payment because the discount off of charges are relatively uniform, probably, maybe. Yes, but that's what they support. Yeah. But we're talking about Medicare payments, so that the charge to payment in Medicare has this huge variance.
Yes, I get that, and it's beyond my pay grade. It does relate to cost reports, settlement of cost reports years later, and a whole bunch of allowed costs, not allowed costs. But that's a lot. I get it. In terms of the reasonableness of our charges, good point, David. We've always said we look at percentage of the Medicare fee schedule and make sure that we're charging at a minimum rate. That's the way we do it, because the worst thing you could ever do is actually have a charge below what they're going to pay you, because they'll pay the lower of cost of charges. When I got here, we had a number of charges that were below what they were paying us, Blue Cross and others, and they were all giddy looking at us going, it's so funny that They don't even, they should know what the charge is. So that's the extent of my knowledge. If I speak anymore, the CFO is gonna tase me.
Okay.
So I'm gonna leave it at that.
Can I ask you one thing on that, which would be super helpful for me to understand is, do you know
Sure.
if that within that Medicare fee schedule that you look at a percentage of for your charges, is that percent uniform across all the charges, or does that vary in different parts of the organization?
I'll have Jeff jump in. I know he's right there.
It will vary, but we try to ensure that when we do our rate increases that we're at a X percent, not too high. So we do check at that.
What's the average percent, Jeff? Give or take, or range?
We start, at 250 of what the Medicare fee is to create it.
Good. I hope that's helpful. This stuff gets very complicated. I appreciate the data, Elena. I'm just sort of curious about how we compare and, making sure that I do know for a lot of the data I've seen, the critical access hospitals, not all of them, but are less expensive than sort of the tertiary care center or the PPS hospitals for the most part. Could be wrong about that, but that's just, all right. Thank you.
Emma?
Hi, Emma Zavas from the Office of the Healthcare Advocate. I think my camera, maybe they'll turn it on. There we go, sort of. All right. So I really appreciate sort of the discussion around this issue and think it's very important. And I guess I just want to kind of bring it back to patients. One thing that was brought up in the presentation by the Green Mountain Care Board staff was the financial assistance programs that hospitals in Vermont offer. So all of our critical access hospitals in Vermont are nonprofits. They're required by law to have financial assistance programs, and those lower cost sharing for people who are income eligible. It's not a perfect solution by any means, but it is a tool that we have at our disposal now, and it is perfectly legal for the critical access hospitals in Vermont to be utilizing that now. One issue is that financial assistance programs are only effective if you are actually screening all of your patients. And Vermont does not have a requirement that every patient be affirmatively screened. But that doesn't mean that hospitals could not voluntarily seek out, that practice, decide to do that. So I guess my high level question for our hospitals is, how will you ensure that all of your Medicare patients are screened for patient financial assistance? And that's the high level question, and that gets at lower level questions of, how many of your Medicare patients are being screened today? How many were approved? How many were denied? What were the reasons for the denial? What is your reach goal? How are you going to increase the number of patients who are being screened for financial assistance to 100%? What's the plan? What are the steps that you're taking? All of those things are available and actions that our hospitals can and should take on behalf of patients. And just to bring it back to that slide 4 from the Green Mountain Care Board's presentation, where they're looking at sort of the costs, how it shakes out for a patient. On the right side, we have the critical access costs. If that patient is under 400% of the federal poverty level, they should have a minimum discount of 40% off their cost sharing charges. That would bring those costs down to $2,520. So that's not quite parity with getting that procedure at a PPS hospital, but it's getting a lot closer. But again, the efficacy of a patient financial assistance program is ensuring that patients are screened and that everyone who qualifies is getting that benefit. There's federal and state law that are already in place, and I really encourage the hospitals to be using that as a tool to move this forward and give some affordability relief to Vermonters. Thank you.
Mike?
Thank you. Thank you, Emma. So one of the things, and you can't see this, and I apologize, but in our draft notice to patients, as Kirk said, we would establish and the board would approve. We actually make sure it points to this this information that you just described around our financial assistance policies. It points to our transparency pricing data. We're talking about making sure that our pricing data is moved to the homepage, and because it's not always intuitive to everybody where it sits and lives. So those are some other things, and really speaking to the fact that having outpatient services at a critical access hospital may be at a higher rate from your cost coverage, really the intent of what is being talked about here. So I think that I believe that gets at your question around our charity care policies and our desire to make sure we touch everybody. So I know in my days of revenue cycle work and finance work at hospitals, and you might even hear this, a big barrier to our charity policy sometimes are our patients or customers individual sort of pride, if you will, and want to pay the bill if they receive the bill and don't want help. We do see that. We have other challenges specific to immigration and laws and challenges there. But by and large, I know that all of our hospitals have a very robust and thorough process, and I'm sure each hospital would speak to that. And I'm not saying that things don't fall through the cracks, and if they fall through the cracks, it's not great. And I just want to acknowledge that too.
Mr. Tester?
Yeah, thank you. And Chair Foster, I just want to open my by expressing my gratitude for what you said earlier. And I think it was the first time in this process that I really heard it, which was we all want to solve this problem without really financially impacting our critical access hospitals. And I think that's a recognition of the important work that we're all doing, serving these rural communities, and which are sometimes often very challenging circumstances. So thank you for saying that. I was wondering, Emma, and because I think we do generally, and I know Mike Fisher, I see him on the call too. I think generally at our hospital, we get relatively high marks for our financial assistance programs here. And correct me if I'm wrong on that, but at least that's the feedback that I feel like we've received. But would it be helpful if I invited Andre, my CFO, to kind of, at least at a high level, describe what we do try to do to route people to financial assistance here? I don't want to take up too much time because I think it probably mirrors what other hospitals do. But if you would find that helpful and moving towards answering some of those questions, we'd be happy to do that.
I think it'd be helpful, Sean, if Andre. Oh, I see Andre. Yeah, Andre, go ahead.
Yeah, he's there. Thank you.
Yeah, we do a lot of things, especially when we find out a patient is either pure self-pay or has self-pay balance after insurance. Can be challenging depending on the patient. We do offer the financial assistance program. One of the other things that we're doing is, and I didn't realize this actually happens for a lot of the Medicare patients that were Medicare Advantage before, and now have switched back over to pure Medicare. There's a mechanism, I think it's an automatic mechanism that actually gets them enrolled on the I guess it's Medicaid Part D is what it's called. It's basically the Medicaid supplemental. It's automatic, and the patient doesn't even know it. So when we see that self-pay come through for every Medicare patient that is coming in, we actually look to see if they have that attached to their insurance and let them know that they have that supplemental automatically. As far as, there's a process, and Mike knows this quite well. There's a process for an application for free care or charity care, which is the process you're talking about, or the law that you're talking about, and making sure we try and capture all of those self-pay, not just Medicare, anybody who may have a self-pay balance. We also we outsource our self-pay statements, and we reach out to the patients through that mechanism
letting them know that we do have this free care program and how to contact our staff. Is that helpful?
The last thing we want is for any of this to go to bad debt or, you know, we really work hard to work with our patients to make sure that they're getting the support they need and that they're obligated to, that we provide them. That said, two other comments I would say, especially, I think this past year's enrollment process, both for Medicare with all the